Good day, everyone. This is the Concept Academy webinar on endocrinology. I'm very sure that majority of us are quite new to the Concept Academy. But this is the platform that prepares you for USMLE, most especially through our material. So before we start, I want to quickly address some misconceptions so that at least you will put your mind at rest. USMLE is actually a very simple exam to approach, most especially if you have the right information. That you need to read a lot before you write the exam is a lie. You don't need to read a lot before you write USMLE. USMLE questions in a way can be predicted. You need long hours of reading is a lie. Even 2 hours of reading consistently will give you amazing results. So even though you are working somewhere and you feel like you want to write USMLE, you can actually still write it. All you need is just basically, like, if it's 2 hours or 3 hours, you can be squeezing out every day. Just be very consistent with it, and you will be amazed at the results. You need to use so many materials before you pass. That is another lie. In fact, that is where most people start getting it wrong. And that is why so many people find it difficult to navigate their way through the exam. They don't even know what is expected. You don't need so many materials. There is a material. We are not an advocate for first aid, but first aid is an amazing material. The information in first aid is actually quite precise, concise, and accurate. So you can just pick the first aid and note those points, and enter into the exam like a pro. You need to solve all questions when you get into the exam. That is another lie. You don't need to solve all questions. As a matter of fact, the people that are preparing for step 2 with us, we've been emphasizing a particular point for them for some time now, and that is the fact that in the exam you don't need to be rushing to solve all questions, because in the course of trying to solve all questions per block, you end up committing all manner of errors, and those errors will now drop the mark. You can actually solve 40 questions and end up getting 20 out of it, not because you don't know, but because you do not really take your time to note what each of those questions is talking about. All because you think you are running out of time. So you can solve 35 questions and score 30 out of 35, and you can rush to solve all the 40 questions and actually end up getting 20 out of the whole entire 40, all because of flimsy error, flimsy mistake. All right. Then you need to solve all questions in your question bank. That is a lie. The exam is not, it's just those question banks, the question in them just give you glimpse of how the exam may look like. Yeah, you may get into exam and see 1 or 2 questions that may look like that. That is fine. It's very, very okay. But that you are going into the exam to be solving U-word question, that is a lie. So someone can solve all the entire U-word and not actually do well in the exam. That is true. And someone might not really solve up to 40% of U-word and still end up solving all questions in the exam. That is very, very true. So take it easy on yourself. That you have a friend beside you that is saying that I've solved 70% of U-word. It doesn't change anything. The person may solve 70% of U-word and might not really understand the gist in each of the questions. So why the rush? Why the comparison? So most of those things you think count, they don't actually count with respect to your success in the exam. You are basically going into the exam to go and think. You are just going there to go and think. And if we leave you alone here to think, you will see how amazing your thinking circuit is. Believe in yourself. All you need to do is to trust. Get the field information, get the question, look at the question, and think about it. You don't need to be perfect while you are preparing for the exam. You are the one taking it too far. No, you don't need to be perfect. Make the error, make the mistake, solve 10 questions, get 3 right. It doesn't mean you will fail. It doesn't mean you will fail. Get 3 right. Be happy. Look at the mistake you've made. Look at them and be like, okay, this is what is going on here. But some people will solve 10 questions and get 3 right and start getting discouraged because they are expecting to be getting 9 out of 10 right. Who does that? As a matter of fact, some professors don't even get all those kind of stuff, even if you allow them to solve the same questions you are solving. So why are you being harsh on yourself? Just take it easy. Yes, you can solve 10 questions in your U-word now and score 6. Please be happy with the process. It's just a process. Within those 6 questions you get right, that might be where the question they will give you in that system, that may be where it's going to come from. But most of the time, the little successes we are supposed to be celebrating, we do not really celebrate those little stuff. So we actually end up focusing on our weaknesses, our errors. That is where we focus on, and we think that we can write the exam. You need high scores in step 2 before you match. That is a lie. You don't need to have high scores, very high scores in step 2 before you actually match. It's a lie. All you need is just to meet the basic requirement. Do the interview. Let them read whatsoever you are supposed to write. Then the next thing, apply for your matching. You are okay. You need to be a genius, or it is an exam for the best. That is a complete lie. As a matter of fact, USMLE is an exam for the average, not for the best. The best are difficult to teach. The average, they are easier to actually give information. In fact, they take it hook and line for the average. So just ask yourself, what are those things that have been holding you back? Writing USMLE or focusing on it. You don't need long months before you write it. You need God or prayer. Very complete truth. You need to be very prayerful. Yes, some people have very great grade. They meet all the requirements. Still, they will not match. And some, they do not really have much, and they are going to match. So if you think that prayer is useless in the journey, then you are committing a very great USMLE blunder. Very big blunder. You need to be very prayerful. Either you pray for yourself or you have someone praying for you. You need any of them. You need any of them. USMLE will consume your money. Very true. You are going to spend money. You are going to spend money while preparing for USMLE. So these are just few lies that actually fly around that you just need to be very clear of. You see, if you are not clear in your head, you will only keep beating around the bush and you will not get any results. Calm yourself down. Focus on the gist or the point. You just need few points. Take those few points into the exam. And so many people that have passed, do they know they will pass? Not completely true. The same fear you are entertaining, they also entertained it. And when they move into the exam, when they were answering the question, all of them, do they know that, wow, I've already bastardized this? Not all. In fact, majority of them, when they were done with the exam, they could only keep their mouth shut. So when you also go into the exam and you feel that way, who told you that you are the only one feeling that way? That's how everybody felt. Most people felt, actually. So just be relaxed. And they still came up. They came out of the stuff victorious. The result was quite amazing. So which means that you can also achieve the same, even with the same experience. All right. So this is the Concept Academy. We are going to take you through Endo now. So don't be looking for stuff. We have no stuff to move for you. We just have to gist around this, so that you have an idea of how USMLE thinking is. So for the Endo, so you are expected to, you will be given questions on embryology, anatomy, physiology, pathology, pharmacology. And for all you care, you may not get up to 5 questions on Endo. So why do you want to kill yourself? So just be relaxed, take it easy, and be prayerful. So this is the first aspect, the endocrine embryology. What they just want you to bring into the exam here basically is just the thyroid development. Just 1 or 2 points, not for you to come and be moving stuff inside the exam like you are a thyroid pioneer. No. So there is what we call the thyroid diverticulum. So that's actually where everything begins. So it arises from the floor of the primitive pharynx. So the next thing you see, just get the gist or the story around it, so that when you are reading the question, you just be like, this makes sense. So the next thing is that it's going to start descending and descend into the neck. That's the thyroid. So you can see the thyroid here now. This is actually where it eventually gets to the anatomical site of the thyroid. This thyroid is still connected to the tongue by a particular dot. We look for a very beautiful name to give it. So we can only give it thyroglossal dot, which is a dot that you can see spanning between the tongue and the thyroid. I'm very sure that's the name you will have given it to. This dot, do you still have it? Actually, it's supposed to disappear, but in some people, it may persist as a cyst. So you will just see a cyst here like this. So you will just see a cyst here like this. Something like this here, a cyst. And you are wondering, what is this bulge here? So when you ask the patient to stick out the tongue, or you stick out your tongue, because the tongue is moving out, you see the cyst will also move. So therefore, you just know that this is a thyroglossal cyst. With respect to you and I, where the dot is actually expected to have disappeared, you will see the remnant. It will leave some structures behind that will show that it was once there. So for the tongue, you are going to be seeing what we call the foramen cecum. With respect to the thyroid, you are going to see what we call the pyramidal lobe of thyroid. When I get into the exam, will they be asking all this? Sincerely speaking, just information. They hardly test those ones, but they can test you on the thyroglossal cyst. The next thing is, doctor, what of if this thyroid does not descend down to get to the anatomical site? It could have been anywhere else. It can be around the tongue, the base of the tongue. It can be around the floor of the tongue. It can be anywhere. So it can be anywhere, but not the anatomical site. So you call those kind of thyroid, you call them ectopic thyroid tissue. So a very common one, the most common one, is what we call the lingual thyroid, the one that is related to the tongue, lingua. So they will just tell you in the exam that you can even think it out Because now that you know that the exam is not basically la cram la pour, you are going there to think. You need to have the gist and now start answering questions, because you will just be thinking that I feel this is what this patient is having. They just tell you that there is a mass here that was removed by Dr. Pisa. So then after the mass was removed, they noticed the patient start having symptoms and signs of hypothyroidism. But you know, they will not mention hypothyroid. So you need to know those symptoms and signs. Do you get me? The skin start appearing dry. The patient start having this cold and the light. The skin starts feeling cold and all manner of stuff. So once you start seeing all those kind of stuff, you'll be like, this patient is already having symptoms and sign of hypothyroidism. So most likely the mass that was removed was actually a thyroid tissue, ectopic. You may not even remember the name, but you will just be like, maybe a thyroid tissue was removed. And that's just that. So that's the kind of question. They will now say, basically for step 1, they will just ask you that what is the most likely attribute of the mass that was removed. You know, they can say that, okay, the mass is supposed to produce T3, T4 or something like that. And I'll be like, yes. So because after removing the mass, the patient start having symptoms and signs of hypothyroidism. Now tell us what is difficult there. You are thinking too far. The thyroglossal dot cyst. So anterior mass, they will just say, okay, the patient has anterior midline neck mass that moves with swallowing or protrusion of the tongue. So what else do you need? You will just be like, okay, most likely I'm dealing with thyroglossal dot cyst. Compared to persistent cervical sinus, this is actually related to pharyngeal cleft, cyst in the lateral neck. So you can actually go, I don't want to be moving around now, but in our videos, we try to show you how the kind of picture you are expecting that they can give you there. They can just show you the neck of someone and just show you something that is draining there and the likes. So that's just by the way. The next thing is thyroid follicular cells. Where is it coming from? Endoderm. Thyroid follicular cells. Thyroid follicular cells. Where is it coming from? Endoderm. What of parafollicular cells? Where are they coming from? They are not actually coming from the fourth pharyngeal pouch. They are actually coming from the neural crest cells. So I actually feel that this is an error that actually needs to be corrected. It doesn't mean that them putting that there, they are wrong, but not completely true. All right, so the parafollicular cells, you call them C cells. The C cell is coming from the fact that they are supposed to secrete calcitonin. So their origin is neural crest cell. So in case you see them mention parafollicular, you know that, okay, this is actually what they are making reference to. So I want to illustrate how they all behave so that you have an idea of how to look at it. So this is what you have. These are the follicle. So you have the follicular cells, thyroid follicle. They are just like this. So for the follicular cells, you see them, they are going to line the follicle, the thyroid follicle. For the parafollicular, you see them in between the follicle here. Here, they are not within the follicle. So you can actually just use that to get 1 or 2 points with respect to that. All right, so that's just by the way for you to have an idea of what is going on. So the follicular cell, you see them lining the thyroid follicles. Parafollicular cells, you see them between follicles within connective tissue. Follicular cells will be producing T4, T3. Parafollicular cell will release calcitonin. All right, so that's basically just by the way. We are going to be looking into the detail of that later. So another important point for us to note is where this fourth pharyngeal pouch now coming from. Well, the fourth pharyngeal pouch usually gives rise to superior parathyroid gland, whereas I'm still going to show you, and what we call the ultimopharyngeal body. So it's just going to give rise to these two. How will I remember it? You worry yourself a lot. Just pick the information. We are still going to show you how to remember it. So another name for the ultimopharyngeal body is ultimobranchial body. Now, this is what happened. The ultimopharyngeal body will now come and fuse itself with the developing thyroid gland. Then you will now have the neural crest cell will now migrate into that ultimopharyngeal body. It's more or less like ultimopharyngeal body is like a bed for those neural crest cells to lay themselves. So then when they get to the ultimopharyngeal body, they now differentiate themselves into parafollicular cells and become integrated into the thyroid gland. So that is where the fourth pharyngeal pouch is coming from. Then you come down here. So in embryology, generally, we have what we call the cleft, the arc, pharyngeal arc, pharyngeal cleft, pharyngeal pouch. So for the pouch, you can actually look at it. C, cleft, A, arc, B, pouch. Can we mute our mics, please? Cleft, arc, pouch. Please help us to mute your mic, please. So cleft, arc, pouch. C, A, P. Take your cap. Like you want to cap something. You can look at it like that. So I put something here. Cap covers outside to inside. You can look at it if you wish, which means that the cap, C in the cap here, cleft, so is related to the ectoderm. A, arc, is related to the mesoderm with neural crest cell. P is related, which is pouch, is related to the endoderm. All right, there is a mnemonic we love to give people when they are going into the exam, and that mnemonic is tap titles. You cannot go into the exam to be tapping the table when you can tap the titles and say, I saw a question on pharyngeal pouch derivative and I don't know what to pick, because you were not informed that you could be tested. Tap titles. So you can be going on the road and just try to remember tap titles. So TAP, TITUS. So for the T and A, they are related to first pharyngeal pouch. For the P and T, they are related to the second pharyngeal pouch. I and T, they are related to third pharyngeal pouch. U and S are related to the fourth pharyngeal pouch. So what is T? Tympanic cavity. A, auditory canal. P, pharyngeal tonsils. T, tonsillar fossa. So second is related to the tonsil. Pharyngeal tonsil, tonsillar fossa. I, inferior parathyroid. T, thymus. U, ultimobrachial body. S, superior parathyroid. Now, this is it. So in the exam, they will just tell you that the patient is having maybe one problem with the fourth pharyngeal pouch. And I'll say, which of the following are you likely to see in this patient? You already know that in one way or the other, the parafollicular cell will be affected. In one way or the other, superior parathyroid will be affected. All right. So for the inferior, for the third pharyngeal pouch, you just look at it. So they might just tell you in the exam that by one reason or the other, the third pharyngeal pouch is affected. So you don't really need to, just need to remember, okay, when I get into the exam or they give me question on tap titles, this is just how I would think it out. You don't need to know how the question will come. They leave the question for them. You just know have the meat with you. You can actually dissect any question. There is a particular microdeletion we call it 22q11.2 microdeletion. So what you see is that this microdeletion underlies the physical, the spectrum of physical features you see in what we call DiGeorge syndrome. So the USMLE love to test this DiGeorge syndrome a lot. Embryologically, what you have is that neural crest cell actually fail to migrate into the derivative of the fourth pharyngeal pouch, the third pharyngeal pouch. So if there is no migration to the third, it means that the inferior parathyroid will not be will not be formed. The thymus will not be formed. Very simple thinking. So the same thing for the fourth pharyngeal. So ultimobrachial body, the superior parathyroid, they are all going to be affected. So what is the consequence of this? So there will be a problem with T cell. So there will be T cell deficiency in the patient. And the patient is also going to have something that looks like hypocalcemia. Very easy. So they will just give one long story and now say on further evaluation, the patient is T cell deficient. They will now say laboratory finding. You look at the calcium, it's very low. They may even give you the parathyroid hormone. You realize that it's very low. What is going on? And the patient is T cell deficient. Just say, hope I'm not dealing with this DiGeorge syndrome of a thing. And just flip through the option and pick something like this. Say you are correct. So that's just by the way. Now, this is the anatomy here, just for you to have an idea of how this could be. So you can actually see the arterial supply, superior thyroid artery. So we also have the inferior thyroid artery. All right. So where is the superior thyroid artery coming from? Superior thyroid artery is coming from external carotid artery. Inferior thyroid artery is coming from thyrocervical trunk. How will I remember this?
Can you hear me? So I was telling him that.
All right. How will I remember this? You can actually use this mnemonic, ESIT, ESIT. You just need to practice it once or twice, and you will get quite used to it. So external carotid artery will give rise to the superior thyroid artery, while the thyrocervical trunk will give rise to the inferior thyroid artery. And that's just that. They say we should just show you, bring it. So what is difficult here? Before you start looking for one anatomy textbook here and there, because you want to go and write USMLE, you are overthinking. All right. So I'm going to leave the rest here. Then you come to what we call the pituitary gland. Pituitary gland is not what you've never heard before. Whether it's recent or it's already late that you actually left school, but it's not what you've never heard before. Therefore, the pituitary, you have anterior and we have posterior. For the anterior, you actually have some hormones that are produced from heat. So you have some hormones that are actually released or produced. So it secretes this hormone. Can you see them? Even so, FSH, LH, ACTH, TSH, prolactin, growth hormone, and beta endorphin. So these are the hormones. Can you see? All right. Now, do I need to cram this hormone to take into the exam? Well, it's not like you are cramming it. You are just noting them. Maybe that's the scientific way of putting it. Just note them. All right. You can call this hormone flat peg. Flat peg. FSH, LH, ACTH, TSH, prolactin, endorphin, growth hormone. Flat peg. Just a flat peg. Anterior pituitary. All right. Now, what are they going to be asking me in the exam basically? Number one. You see this ACTH. You cannot enter into that exam without knowing from which molecule is it produced from. It's not allowed under USMLE law. ACTH is produced from a particular molecule. You call it pro-opiomelanocortin. That is where it's produced from. So anytime ACTH is released, there are some other guys that will also be released together with it. So, and these are those guys. Beta endorphin, MSH, beta endorphin, MSH. Two of them will be released together with ACTH from this pro-pure-melanocortin. So you can give this a mnemonic BAM. So what is MSH? Melanocyte stimulating hormone. So another name you can call it is melanocortin. So melanocyte stimulating hormone. So melanocyte stimulating hormone. So beta endorphin, ACTH, MSH. Can you see? BAM. So now this is how question will come here. In any situation where ACTH is overproduced, you realize that the patient will look darker. The patient will be appearing dark. You will be seeing hyperpigmentation. Hyperpigmentation. They will just say, like, what do you think is responsible for it? This is just it. MSH. There is no too much thinking there. Just pick it and be like, because as those ACTH level, ACTH is being released, MSH is also released together with it. And that's just the main point you are taking. You can go and be thinking anyhow you want to think around it. Now, another question you can expect from here is a table question. So they will just give you a table. So like this. And portray a situation where ACTH is overly produced. And they will just tell you that what do you think will happen to ACTH level? What do you think will happen to the beta endorphin level? What do you think will happen to the MSH level? So those are harrow questions. Just say in this patient, ACTH is high. Beta endorphin also will be high. MSH also will be high. And you will just pick your answer without overthinking. This is the concept there. It's not going to change. That is how it has been for so many decades. So it's not next year or this year that is now going to change. It doesn't change. The next thing, important point you are expecting is about where is the anterior pituitary actually derived from. It's actually derived from what we call the Rantke pouch. I put an arrow on it. Expect it in the exam. They will just give you an MRI and just put a lesion there. They will just say that you realize that the lesion is actually in the pituitary. Now say, so the structure that is affected in this patient is derived from which of the following? That's all. Rantke pouch. Rantke pouch. So that's just by the way. All right. When it comes to these hormones, you also divide them into two categories. You can divide them into two categories like this. Permit me. So for the flat, I'm going to remove this endorphin and just focus on the prolactin and the growth hormone. I will remove this endorphin now for what I want to analyze now. So for the flat, which category of cell is actually going to produce them? For the P and G, which category of cell is going to produce them? Okay, so we have what we call the basophilic cell. We have the acidophilic cell. You can look at them like that. The basophilic cell, acidophilic cell. So I want to arrange these two letters on flat and peg. In school, we can actually say flat B, and I can say a peg, a peg, a peg. But can I say a flat? Yes, I can say a flat. But can I say B peg? It's not possible. It doesn't sound right. So I just arrange it with that common sense. I just say, okay, B flat, A peg. So which means all these flat, they are basophilic in origin. They are basophil in origin. Why the acidophil? This P and G, they are actually more of acidophil. All right, or you just say they are acidophilic. Let me put it that way. So if you say they are acidophil, so which means that when you stain them, they are actually going to look a bit pink. Then for the basophil, they will look a bit blue. That's the next point. So in case, so now think about it. Let me set a question here. This also patient with this also condition, blah blah blah, with further evaluation, and this one, they notice that this also condition destroy the acidophilic cells of the pituitary. Which of the following hormone is most likely going to be deficient in this patient. Tell me how that one is a big deal. If you destroy the acidophilic cells, then the prolactin and the growth hormone will not really be released. The patient will be deficient of prolactin, will be deficient of growth hormone. So this also patient having this, having that, blah blah blah, blah blah, blah blah blah, blah blah. The basophils are destroyed. Which of the following is likely to be present in this patient? They now give you a table. FSH, LH, ACTH, TSH, PRH. They put arrow there. You already know that all these flats, B flat, all of them will be down. Why these acidophil, PRL, the prolactin and growth hormone, they will be normal. How is that difficult? You are the one overthinking. The last but not the least point here is about the subunit of these hormones. So we notice we have two subunits, alpha subunit basically, beta subunit. What is the essence of alpha subunit? So you see this alpha subunit is actually similar between some of these hormones. TSH alpha subunit is similar to HCG alpha subunit. So I want to compare these guys with HCG. TSH alpha subunit is similar to one hormone somewhere. You call his name HCG. We say, is it only TSH? They say it's not the only one. There is also another one that look like it. LH2 alpha subunit also. FSH, but the most important one is this TSH and HCG. They are just the most tested in the exam. How are they going to test this? Which means this is what happened. In any situation where the HCG level is very high, HCG, because the alpha subunit look like that of the TSH, it can go to the TSH receptor and be romancing it. And just say I should come and greet you. Say, you don't look like HCG. Look at my back now. I look at it. I look like it. So the patient start having symptoms and signs of hyperthyroidism. You may be wondering why choriocarcinoma patients can have symptoms and signs of hyperthyroidism. This is the reason. Because their alpha subunit look alike. Of what? TSH and the HCG. In choriocarcinoma, the oval produce HCG. So those HCG will now go to the TSH receptor and just start stimulating them. So you just realize that the patient start producing all those and thyroid hormone. But when you check for the TSH itself, so you just be wondering, where is it coming from? Where is all this thing coming from? What is going on? Because TSH picture will not reflect it. That is for the alpha subunit. The next one is the beta subunit. With respect to the beta subunit, that is what make TSH, LH, FSH. It gives them their specificity. HCG. So beta subunit is what determines the hormone specificity. And you are done preparing for any question here. There is no question you want to bring out anywhere that you understanding this will not really help you out with it. You don't need to have solved 1 million questions. You can spend 5 minutes revising this, get into the exam, and your thinking is as sharp as a two-edged sword. And you can ignore this point and go and solve 50-something questions somewhere. And you can't get into your exam. They now change the question a bit and you can't even think it out. Which one do you prefer? Look at the posterior pituitary. The hormones they say posterior pituitary produce, they are not strange hormones to you. Is it vasopressin or the oxytocin you've never had before? All right. So the vasopressin, oxytocin, they are actually produced in the hypothalamus, to be very precise, but they will be taken to the posterior pituitary for storage. All right. So now, where is vasopressin coming from? Which cell is actually, or which nuclei rather? They are the one we call cells. So which nuclei are producing vasopressin? Which nuclei are producing oxytocin? You see, there are two nuclei we have with respect to these guys. We have the supraoptic, we have the paraventricular. Supraoptic, we produce both of them. Paraventricular, we produce both of them. However, supraoptic, we produce more of ADH, which is also called vasopressin, and the paraventricular, we produce more of oxytocin. Get the gist? I said something. Each of them, supraoptic, paraventricular, produce both of them. But supraoptic, we produce more of ADH. Paraventricular, we produce more of oxytocin. And that's just a point. We give it this name on a sad pox. Why must you be sad when sad pox is with you to use? You say, I can't remember how to use it. Use what exactly? Just pick a sheet of paper, you write it down, you rehearse it, you look into the sky, you look down, you look to the side, you look to the left. You are inside the toilet, you see say sad pox. And you just think about it within few seconds. You say, okay, I've mastered that. And that's that. Where is the posterior pituitary derived from? Neuroectoderm. This is neuroectoderm. I put an arrow on it because it's not a joke in the exam. Then you come to the adrenal cortex. This is the adrenal cortex. You've already heard about it. And if at all I ask us all here that beyond the stuff that you've mastered, what's the first thing you have mastered about the adrenal cortex? Everyone will say GFR. This is a very beautiful mnemonics we were using then. Say GFR. So that's just for you to have an idea of arrangement of the zone you have in the adrenal cortex. From outside, inside. Zona glomerulosa, zona fasciculata, zona reticularis. It's quite funny. Some people will still think this GFR is not complex enough. They will drop it. They just love to think in a very complex way. GFR, very simple. What are the questions you may be expecting? Where is the cortex derived from? Mesoderm. Again, mesoderm. What USMLE would do for step 1 basically is to...
They're very poor now.
All right. So what USMLE will do basically is actually to give this slide so they can give a very big version of it. So they will just ask, they can put an arrow on anywhere and just say that, like, which zone is this, or which hormone is produced here, and the likes. All right, so this is like a kind of question you are expecting. You just want to have a way of looking at it. So this is the cortex, zona glomerulosa, fasciculata, reticularis. So definitely, if you get into the exam and you see them put an arrow here, you just know that this is until proven otherwise. Fasciculata is a lighter zone area. It's very light. That's what they want you to pick. It's light. So now, if they now put an arrow on this area, how will I know that this area is glomerulosa? The one that I'm seeing beneath here is actually reticularis. How will I know? Look at what is aborting each of these zones. This one upper, and the lower one here. Can you see here? So what is aborting it here? The zone that is aborting it, the area that is aborting it here is actually the medulla. So the medulla area is pigmented. So this area is going to be pigmented. That is how I will know that this is reticularis. While the area that is above this area, this glomerulosa, is actually just more or less like a fat layer. Can you see? They call it capsule, something like that. You just see it. So which means this area is most likely going to be light. Can you see? This area here, because what you have there is just more or less like fat tissue. And that's how you identify it. Basically, that's just what you need here. Which hormone is produced from glomerulosa? Mineralocorticoid. Which hormone is produced from fasciculata? Glucocorticoid. Which one is produced from reticularis? Androgen. Then for the medulla, catecholamine. Very easy. And they say, okay, you have tried. Drop that. You come to the pancreas. This is the pancreas. So we have this collection of cells that are like the basic ones you don't want to forget. The alpha cells, the beta cells, the delta cells. What do you want to take into the exam? Is it just to look at it and say, okay? So it's just the arrangement. The arrangement. So how do they arrange themselves? You can look at it like this. You don't need to be accurate. You can say here, I'm going to see the alpha. Inside, I'm going to see the beta. In between or around, I'm going to see the delta, something like that. So now, they can now tell you that, okay, this patient has like inflammation that is affecting the peripheral part of the pancreas. They now say which of the following cells is most likely going to be affected, alpha cells. This patient has this also condition that is affecting central part of the pancreas. So you say which of the following cells is most likely going to be affected. You say the beta cells. Can you see the way you are doing the thinking? So you just say the beta cells. All right. So basically about, inflammation is more around the peripheral. Inflammation is more about the central. Just a very simple thinking there. Then you've tried. Move on. So that when you get into the exam, you see that you won't say that, I'm confused. No. This is a table. No one needs you to cram this table. Just get the gist and move on. So these are the hormones. First of them is ADH. What will ADH do? ADH helps with water reabsorption, where collecting duct. Also, the distal convoluted tubule. So just going to be basically the collecting duct anyways. All right. At least everybody knows that. You think about it. They will now give you someone that is consuming alcohol. That's the advantage of first aid. First aid is very precise. Just tell you that, and this also patient he has been having polyuria. So the patient is also has alcohol use disorder. They say someone has alcohol use disorder is not just a compliment. It is an attribute to the person that this person cannot do without taking alcohol, and the person is having polyuria. So immediately you see that, they now say that which of the following, what is the most likely mechanism that underlies the polyuria this patient has? That don't be thinking too far. Someone that takes alcohol, so alcohol consumption is going to reduce the ADH secretion. So, and that patient is now going to end up having polyuria. If the ADH is not released, nothing to cause reabsorption of water from the nephron. So most of those water will be lost in the urine. So, and the patient will now be having polyuria. And eventually the patient can become dehydrated. So what are we trying to say? Alcohol consumption reduce ADH secretion. What is difficult in that? They give you one, you are still looking for additional 3. You are a confused person, sincerely speaking. Just take this and master it. Then you move on. That's why we say that USMLE is more of an exam for an average person, not for the genius. Genius will not stay here. Genius is the one that will still be, what test can it be? What test can it be? The exam does not work that way. You will just be loading yourself with too much information. Then you come here again with respect to this CRH. In the exam, this is corticotropin releasing hormone. What is corticotropin? Another name for ACTH is corticotropin. So releasing hormone, all releasing hormones, they are coming from the hypothalamus basically. So corticotropin releasing hormone. So what it means is that this hormone is going to act on the anterior pituitary and favors the release of ACTH. You now ask yourself, I learned that anytime ACTH wants to be released, there are 2 entourage that will be released with it. What are they? Beta endorphin and MSH. So which means when they tell you this patient has high level of CRH, they now give you a table. They now say what will happen to ACTH, what will happen to MSH, what will happen to beta endorphin. You now remember that concept again and say that, it's going to actually cause ACTH to be high, MSH to be high, beta endorphin to be high, because the 3 of them comes from the same mother molecule. proopiomelanocortin. Very easy. CRH can be reduced in a patient that is on glucocorticoid, chronic glucocorticoid user. So CRH level will be low in them. This is another one. MSH itself. MSH. I just bring this one out. MSH. So that's melanocyte stimulating hormone. So this one will come to the melanocyte and stimulate them. So it's going to increase melanogenesis by the melanocyte. They start releasing melanin. So the patient, you just see the patient will be having hyperpigmentation. And you see this being tested with respect to Cushing disease. Hyperpigmentation you see in a patient that is having Cushing disease. So in Cushing disease, basically you realize that there is ACTH overproduction. So as their ACTH level is high, you realize that MSH level also will rise. And the patient will be having hyperpigmentation. Shikina. So it's all about hyperpigmentation. I put something here, hyperpigmentation in question. Hope it's not related to MSH. Proopiomelanocortin saga. So the question may be related to this BAM. Shikina. The next important point to come and address is about the dopamine. How on earth will you go into the exam and say, I left dopamine there because I don't like the name? You must be a joker. No, you are a comedian. How will you go and say that I left dopamine at home? I just don't like the way the name sound. It's not possible. It's one of the most tested concepts in the exam. Dopamine. What will dopamine do? We give dopamine a well-decorated name. We say dopamine. You shall also be called prolactin inhibiting factor, PIF. What does this mean? In any situation where the dopamine level is high, the prolactin level will drop. So we thought this is just going to affect the prolactin alone, but it also affects the TSH. So which means that when the dopamine level is high, prolactin will be low, TSH will be low. Very easy. So under which condition will dopamine now be very high? All right. They can give you all manner of clinical scenario. Under which condition will the dopamine level be low? If the dopamine level is low, prolactin will now be high, TSH will now be high. So which condition will the dopamine level be low? So you can actually see something that may make that in a patient that is taking dopamine antagonist, like antipsychotic. They will just tell you that this patient is on antipsychotic, which is dopamine antagonist. So, and the patient starts having galactoria. And you are wondering, where is the galactoria coming from? It's because that antipsychotic drug, alloperidol and the likes, they are already inhibited the dopamine receptor. So the dopamine effect is not going to be seen. So prolactin level will now be very high. So you will now see hyperprolactinemia, which is now the one causing the galactoria. In them again, you will see the TSH level will be high. So look at it like this. Two of them together. Don't separate them. Don't separate them. Don't separate them. So that's that. They can also give you a question like this, that someone had an accident and they notice that after that accident, the person had an injury or something. After that, the patient starts having the prolactin level start rising. You don't even need to understand. You want to just see this prolactin just going up and down and the likes. Just be like, oh, this has nothing to do with dopamine. It's just as easy as that. You just look like you know a lot and you are only just staying with concepts. Don't go and be overthinking. There is a song, overthinking no fit solve problem. It doesn't solve the problem. I'm thinking. Just think simply and let them say you are wrong. All right, so that's just about this. You can expand that anyhow you like. There is another hormone that we can correlate with that, and that is TRH. TRH. Thyrotropin releasing hormone. What is thyrotropin? TSH. So anytime the TRH level is high, TSH will be released. Prolactin also will be released. Can you see? Prolactin level will rise, TSH will rise. So you can just see that TSH, you can relate TSH with, you can relate TSH and prolactin with TRH. You can relate TSH and prolactin with dopamine. When the level of dopamine is high, these guys will be low. When the level of TRH is high, these guys will be high. Can you see the difference between TRH and dopamine? So in any situation where the TRH level is now high, you get, so in such situation, you see these two guys also being high. So a very good example, you can see the TRH being high in a patient that is having primary hypothyroidism or secondary hypothyroidism. So they will just tell you that this patient is having hypothyroidism and is having galactoria. They just tell you, all you need to do is just to calm yourself down. You already know where the concept is coming from. And now say, okay, this is primary hypothyroidism. The thyroid gland is not releasing the hormone. Okay, if that is the case, the hormone is low, the negative feedback is reduced. Okay, the TRH level will now be high. So high level of TRH is now going to make TSH to be high, the prolactin also to be high. Okay, the high level of prolactin is now what is causing the galactoria. You just need to relax and say it. Just link them together. So can you see the way you look at that? The next one is the growth hormone releasing hormone. So growth hormone releasing hormone, definitely from the name, is going to favor the release of growth hormone. So that's what you have here. Just going to make the growth hormone to be released. Now, there is a concept here you must never forget. First aid is very precise. It's very, very precise. So first aid, that is the growth hormone releasing hormone analog, tesamorelin. Tesamorelin. So we usually use this in HIV-associated lipodystrophy. You are like, what is HIV-associated lipodystrophy now? So if you don't mind, you can permit me to just show you a concept on that. So HIV-associated lipodystrophy. Let me show you something. So this is just someone that is having HIV. I don't even know which one to. So I will just flip through some pictures. So look at this picture. So this is someone that is having HIV. You just see that there are some regions in the patient body where you see a lot of lipid deposit. Can you see it? All because this patient has HIV and you are treating it. So you check this area, you are saying, Mr. Kokum below. You say, yes, doc. This one that this thing is, what is going on here? Yeah, that's how it was even my wife that told me that I'm already eating so much. Well, I think she's taking care of me. This does not look like care. So this looks like a clinical condition. So from the treatment the patient is having, so excessive fat deposit, it can be in some other region. So that's number one. It could also be related to excessive fat loss. You can look at this picture and you just realize that let me assume that the same person, but you say your wife is taking care of it. What is now going on here? You are losing some fat here. It seems as if your wife is scraping fat here and depositing those fats at your back. I'll be like, just laugh around it. So that's HIV-associated lipodystrophy. So some areas will be having excessive fat loss. Some areas will be having excessive fat gain. So that's HIV. And that's just related to the treatment. So lipoatrophy, fat loss. Lipohypertrophy, fat gain. So the lipoatrophy is related to the nucleoside reverse transcriptase inhibitor that possibly part of the drug the patient is taking. While the lipohypertrophy is related to the protease inhibitor, which is possibly part of the drug the patient is taking. So the patient may actually have the combination of both of them, lipoatrophy, lipohypertrophy. So there is now a drug that can actually solve the problem. Say, Mrs. Lagbaja, weep no more. You say, my husband is becoming disfigured. This, that. You say, weep no more. Tesamorelin will do the magic. Which drug is that? It's actually growth hormone releasing hormone. You just need to make a gist around it and laugh, and just for you to have an idea. You just need idea. You don't need too much stuff. You just want to be like, okay, I will look at it like this, basically, and you are okay. So that's about this. So you can imagine it, you can think about it, and it just give you this headacheless thinking. This is another one, gonadotrophin releasing hormone. These are the gonadotrophin, FSH, LH. Do you think USMLE, do you think they are dumb? That, oh, they just want to be testing on gonadotrophin releasing hormone? Do you know them? That's not the exam. The exam is basically how this hormone is released. All right, how this hormone is released. So we have two release: tonic gonadotrophin releasing hormone analog. The thing we just is more or less like a pause. I mean, tonic is more like continuous. That is tonic. So continuous release, that is that. Then pulsatile release. So it's just more or less like a pause. Bam, it comes. It will be high now. Then it will also be high later. So not that it's going to be high continuously. So pulsatile. These are just the two. What is the difference? The tonic we normally use. Use the tonic gonadotrophin releasing hormone analog to actually suppress this hypothalamic pituitary gonadal axis. Can you see? So which means that if at all we want to suppress all these FSH-LH saga, we can actually still give these guys, but the patient will be taking the drug continuously. All right. So pulsatile release, we can use this to actually stimulate puberty, fertility. The patient will just take it just more or less like for maybe few moments or one time. So for example, now for someone that is having infertility, we can give this patient, we can actually give the patient what do we call it, the gonadotrophin releasing hormone drug, but it's just going to be like a pause, like one time or occasional, not that the patient will be taking it continuously. So it's more or less about, do I understand the difference between tonic, which is continuous, or pulsatile, which is more or less like one time or just occasionally. The patient will just take it, bam, so it will do the magic. So continuous is the same thing as tonic. This is inhibitory, while the pulsatile is stimulatory. And that's the basic thing. So gonadotrophin releasing hormone. So please never forget these guys. All right. The next one is again, all right, prolactin. It's a high level of prolactin. What can it do? It can actually reduce the gonadotrophin releasing hormone. So if it's reducing them, you realize that FSH is down, LH is down, blah, 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 and the likes. So in a patient that is having pituitary prolactinoma, so pituitary prolactinoma, so the prolactin level will be very, very high. So you'll just be seeing something that look like this amenorrhea, osteoporosis, and the likes. So high level of prolactin will inhibit or reduce the secretion of gonadotrophin releasing hormone. So FSH, LH level also will drop. So the patient will be having something that look like delayed postpartum ovulation, most especially if you are dealing with a breastfeeding patient. And that's all. That's why during breastfeeding, the possibility that they can get pregnant is very low. You call that natural contraception. That's by the way. You have another one here, you call it somatostatin. Somatostatin. So somatostatin is one of the few hormones that if you forget them, you need to be crucified, head down. No one will take it slightly with you, whether they ask question on it or not. So they can reduce the release of growth hormone, reduce the release of TSH. So another name for somatostatin is growth hormone inhibitory hormone. And that's just that about the table. So you can sit down with this table within 20 minutes and just pick up your pen and paper and just look at look at them like that, say them, write them, explain them to yourself, and you realize that you're already okay. This is growth hormone. What is going on in growth hormone? CT. Growth hormone, there is what we call growth hormone releasing hormone. Can you see it? There are two sides to it. This growth hormone release, this is where everything starts from. And I want you to listen attentively and get the gist. So this is growth hormone releasing hormone. It can actually be increased. When you sleep, we ask you, go and sleep. You say, no, I'm not sleeping. I don't like to sleep. So the growth hormone releasing hormone level is actually going to, this is going to be stimulated. I mean, sleep is going to be to stimulate it. So someone that's not really sleeping as such, so the growth hormone releasing hormone level will drop. Hypoglycemia. Hypoglycemia actually has a way of stimulating this growth hormone releasing hormone. Stress, growth hormone releasing hormone. Puberty, exercise, growth hormone releasing hormone. You see, aging, obesity, hyperglycemia. Hyperglycemia will inhibit growth hormone releasing hormone. This is a very powerful concept in Africa. And I'm still going to relate it to heat. So the growth hormone releasing hormone is eventually released. From the name, you already know the magic it performs. It's supposed to come to the anterior pituitary and command those cells. Command those cells to be like, oh yeah, release the growth hormone. So growth hormone is now released. You call those cells the growth hormone releasing cells. You can call them somatotrophs. So the growth hormone that is now released will come to the liver and say that, I'm a very big guy. He say, yes, we know. I can't be doing most of this function by myself. He say, we know. Mr. Liver, can you help me do most of my function? He say, definitely I can help you. But I will send one of my entourage to go or one of my messengers to go and execute them for you. So growth hormone will stimulate the liver. The liver will release IGF-1, which you call insulin-like growth factor 1, somatomedin C. The mediator of the maybe somatotrophic function, something like that. You can look at it like that if you wish. So this is IGF-1. So what does this mean? It is a crime for you to say, I remember everything about growth hormone, but I forgot IGF-1. So what do you now remember? How is he executing most of the function? Maybe he's executing it through this IGF-1. It's not possible for you to forget it. Who is going to forgive you? When you become professor and you remember, you will laugh at yourself. IGF-1. What will this IGF-1 do? So see what it's going to do. It will cause the growth. Come to the bone, make the bone to grow. Come to the muscle, make the muscle to grow. Does it have anything to do with fat? No, it doesn't do anything on fat. You see, growth hormone, say, Mr. Liver, those fatty tissue, leave them for me, myself, I will deal with them. Growth hormone actually breaks down fat. So its effect on the fat tissue is actually lipolytic in nature. It's going to break them down. Now, relax. Come back here. I would love to relate it like this. In Africa, people hardly have the opportunity of even eating twice in a day. Those children and the likes. So some of them don't really have the opportunity of having all manner of food in between. So let me assume that they have some levels of reduced sugar level in their blood. It's just an assumption. The nature of everything in Africa, way of life, very stressful. Please help us to mute your mic. Help us to mute your mic. Please help us to mute your mic. Once you know you are in a noisy place. So the way of life is very stressful. So, when we were young, we run around, running from one house, rolling the tire. So, and at night, we sleep and bed wet. We sleep very well. So all those release the growth hormone, releasing hormone. They stimulate the release. We were growing, but we didn't know. So the growth hormone releasing hormone will be released. So the high level of growth hormone in our body that time did not actually allow us to have fat, because it kept on breaking down our fat. So we were looking skinny, but our muscle was being well developed. Our bones were very strong. Compared to that family friend of ours that live in the city, where they eat like 10 times in a day, with as they are eating fish, chocolate, and all manner of stuffs. They are always having high level of sugar in their body. They don't really release growth hormone releasing hormone. So the level of growth hormone in them is very low. So when you look at them, the fat in them is not broken down. So they look very big and chubby. But misconception did not allow us rest. We were always thinking they were the one looking okay. So their bone weak, muscle weak, fat big. So they are very big and chubby. So, and that's the difference you need to actually understand. So when you are reading the question, you can relate it to wherever you are coming from. If at all it fits into it. If it doesn't fit into it, please disregard that and move on. So, but never forget somatomedin C. Never forget that the growth hormone itself handle fat. So in a situation where the level of fat, of growth hormone is very high, the fat level will be very low. So that's why when you see someone that is always eating, they start looking big. So it doesn't mean they are growing. So it just means that they have low level of growth hormone to deal with those fats. So now, is there another point we need to note? It's just basically about what I circled here. So you can see excessive growth hormone, secretion of growth hormone. You can see this in pituitary adenoma. So, and it can cause acromegaly in adults, gigantism in children. How do you want to solve this? So you can actually solve it somatostatin analogotroide or surgery. This is antidiuretic hormone again. You call it vasopressin. The same antidiuretic ADH we mentioned, yes. So what do I want to remember or take into the exam? First of all, where is it produced from? You say the hypothalamus. Which of the nuclei? You say both of them. Both of them. But it's more, it's produced more in the supraoptic nuclei. So where is it now stored? It is stored and secreted by the posterior pituitary. That's very okay. The next thing is that you want to remember for the exam this receptor, the V1 receptor, the V2 receptor. How do they work? So with respect to the blood pressure, V1 receptor is actually the one that is going to be influenced in regulating the blood pressure. So let me write the blood pressure for you. So this is the blood pressure. So you can see this L here. You can look at it as V1 receptor. So for the V2 receptor, you regulate the serum osmolality or osmolarity. Anyhow you look at it, osmolarity. So when the serum osmolality is very high, so the concentration is very high in the blood, ADH is going to be released and it's going to cause reabsorption of water into the blood. Oh yeah, come and dilute it. Come and dilute. The blood is highly concentrated. Come and dilute it. So you see, it's going to come to the collecting duct, cause reabsorption of water into the blood to dilute the concentrated blood, highly osmolar blood or plasma. And that's just by the way. So how is it going to do that? You can be looking at that in renal. You don't need to give yourself headache here. So which condition are they going to be talking about with respect to ADH later? So, and that is diabetes insipidus. So in a situation where we have ADH level production being reduced, You call that central DI. So when you check the question, the ADH level is very low. So that is central DI. What of nephrogenic DI? The ADH can be normal, it can even be increased, but we are not seeing the function. That is nephrogenic DI. So you looking at the question alone, and we are seeing that with further analysis, ADH level is very high. You know that is nephrogenic. ADH level is low, and you are not seeing it, so that is central DI. We will still be looking at that later. There is one more function of ADH that if you forget it, you are just a joker. You are a comedian. What is that? The fact that it increases the urea reabsorption in the collecting duct. You can't forget this. What is the significance? It's actually going to increase what we call the corticomedullary gradient, just to facilitate urine concentration. Well, how else can I break this down for you? This is endo. I'm not going to break it down further than this. So when we get to, you have the opportunity of looking at our nephro, you will see the simplicity of this point and how questions can actually come. They will just ask you that which of the following molecule is important in increasing the corticomedullary gradient. So, and all manner of stuff. Just note that urea reabsorption, you need ADH for it to be reabsorbed. This is the prolactin again. First stage is still bringing out prolactin. They say, we know we've told you before, but we are coming again to tell you that the key expect it in the exam. Why? Why are you telling me? Say, because we know they are most likely going to give you a question on it. And you don't even need to sit down and be cramming any jargons here. You remember, when it comes to prolactin, TRH, will cause its secretion, its release to be increased. Dopamine will cause its release to be reduced. And basically, that is just what you want to remind yourself again and again. You can pick a sheet of paper and just write it there, and just note one or two other points I will mention and just move on. You are okay. Whether you solve question or you don't solve question, when you get into the exam, it shall speak. TRH will stimulate the prolactin to be released. Dopamine will inhibit the prolactin from being released. All right. Okay. I remember, you see, when the level of prolactin is very, very high in a male, you realize that they can also have reduced libido. So when they come to the clinic, even when you are actually assessing them for infertility, you also do not want to be holding back, even requesting for what we call the prolactin in that male. You also want to note that very, very well, because for all you care, it could actually be very high in that male. So that's just how you look at it. Very easy and without unnecessary headache. So the exam will basically just mention it. You are not going to be synthesizing most of these points in the exam. They will all be given. So all you need to do is to look, you think, and you pick. You look, you think, and you pick. You can't think, you are going to be picking wrongly. Even that thing you think you know, you will pick wrong answer. Go and try it in all your questions. You must look, you must think. How come doctors in United States are very good? Because they think. You can't practice there if you can't be thinking. All you want to do is to cram something. So you are not going to be cramming clinical condition. You will see a patient, you will look, you will hear, you will think, and you will write the diagnosis down and say that this is what the patient will need. So very easy. All this inhibit ovulation in female, spermatogenesis in male. For all you care, it's just the high level of prolactin that may just be causing that problem in that guy or that's boyfriend of that patient. But no one checks for it. High level of prolactin is just very high there. So no one checks for it. They just assume that it's another problem entirely. be informed. All right. How is it regulated? For the regulation, you don't need any, you just think about TRH and you also think about dopamine again, just those two. So now think about it. You already know if you are thinking about TRH, then your thinking is most likely going to revolve around anything that is going to make the TRH level to be high. So primary or secondary hypothyroidism. Do you get it? All right. So with respect to the dopamine, so if the dopamine is inhibiting prolactin, it shows that anytime the patient is taking dopamine antagonist, the prolactin level is going to now rise. So dopamine antagonist and one more hormone will actually make the level of prolactin to be high. So what are those dopamine antagonists? Antipsychotic, metoclopramide. The other hormone is estrogen. Now, I want to really explain this area a bit. So that's the reason why you see someone that is on antipsychotic, I've explained it before, you see that the patient can actually be having, what do we call it, galactorrhea. So this is the concept. You just need to write down the statement and it makes sense. So then metoclopramide. You realize that when patients deliver in the hospital, you say, madam. You say, yes, doc. Thank you so much. Thank you. You see my baby. Say, are you lactating? You say, doctor, that's the problem. Say, I'm going to discuss with you. I've not really been lactating. I don't know what is going on. So sometimes what you do is to place them on metoclopramide. You just say, okay, I'm going to write a drug for you. Just take it for like the next 3 days or so. And the next thing you see that doctor is already coming. Wow, that drug is a magical drug. So because it has dopamine antagonist effect, so it's going to make the prolactin level to rise. So can you see? So that's that. Then another one is OCP. Some people may actually be taking OCP and they will be having what do we call it? They will be having level of prolactin actually being, rising. So you need to be very careful before you diagnose that patient for galactorrhea. Take the detailed history. Check which one are you taking. Just don't forget estrogen no matter what. So that's just the summary I'm going to leave with us here. If at all we want to reduce the production of prolactin, we can reduce it by giving the patient dopamine agonist drug. Because we know that when the dopamine is working well, it's going to inhibit the prolactin. What are they? Bromocriptine, cabergoline. So very easy. So a patient that is having high level of prolactin, say which of the following drug will the patient take? Bromocriptine, cabergoline. So if you look at, where is the headache there? Some people will sit down and be cramming this diagram. So now, wow. So you don't need all those. Just want to get the gist because they will always set the question. You come down to the thyroid hormone. Thyroid hormone. We have the T3. We have the T4. All right. Thyroid hormones, they are actually produced by the follicular cells. You already know the follicular cells. So they are produced by the follicular cells. That's number one. We have the T3. We have the T4. There is one more I'm going to mention, but not now. I'm very sure when you are reading your book, you get to thyroid hormone. You are most likely to have this flashback to when you were doing physiology in med school. And they were talking about all this. They were mentioning all manner of enzyme and showing you how the thyroid hormones are produced. Yes, we know you actually love it that time. But so sorry to disappoint you. You don't need those jargons in the exam. You are not a physiologist. You are a medical doctor. So what you want to do is to pick the main point, leave the detail, and make your diagnosis. So there are two enzymes you are going to be focusing on in the exam. The first one is the thyroid peroxidase. This is the point. If I thought they are going to test any enzyme on this thyroid hormone synthesis in the exam, the possibility, there are just two they are most likely going to test. Thyroid peroxidase. The second one, 5-deiodinase. We lay before you this day, life and headache. Pick one. You want to go and be cramming all those or that the way they are. Just be like, okay, I know that there are two enzymes there, thyroid peroxidase. So now this is how you now do your thinking. When you get into exam and you realize that they are just asking about which enzyme catalyzes this reaction, you don't need to remember. The only reaction you need to remember is the one catalyzed by this 5-deiodinase. So which is actually the conversion of T4 to T3. You are removing one iodine. Can you see? So T4 to T3. This is the only one. In as much that reaction they are talking about does not look like the one catalyzed by 5-deiodinase, your answer is thyroid peroxidase. Someone is saying here, and how is the reaction? Which one will occur first? It's none of your business. It's none of your business. That is for the physiologist. They should go and be linking them together. You just pick thyroid peroxidase. You are okay. You have done well. So in as much the reaction they are describing does not look like conversion of T4 to T3, they ask you which enzyme will catalyze this also reaction. Just pick thyroid peroxidase. You are okay. That's the most likely, which means that when you look at that question, you may not really even, you just know that they are trying to test one enzyme and you still want to pick one. You can use statistics to actually pick the correct one, that the most tested of the enzyme is the thyroid peroxidase. Let me assume that you have 10 seconds left before that block will close, and you look at the question is all about enzyme. You now see thyroid peroxidase there. So you can actually just be like, let me just pick thyroid peroxidase and let the thing close up. The possibility you will get the question right, even though you didn't read it, is high. Thyroid peroxidase. That's why you just put the arrow on it. So instead of you saying how does oxidation occur, no one will care about all those ones. Organification, no one really care about all those ones. Coupling, no one really care about all those ones. But the enzyme that will help them is thyroid peroxidase. So that's just by the way. So 5-deiodinase will convert T4 to T3 where? In the peripheral tissue. All right, now let's come. This 5-deiodinase can actually be inhibited. Yes, it can be inhibited by these guys. The glucocorticoid, beta blocker, the propyltyrosine, so PTU. So it can be inhibited by glucocorticoid, beta blocker, First of all, note these three before you be looking for the others. If you can note them: glucocorticoid, beta blocker, PTU. All right. So that's a very good concept about the enzyme. The next concept I want to introduce to you is what we call, so we've done this, is what we call Euthyroid 6 syndrome. Euthyroid 6 syndrome. God is so wonderful. God is so wonderful. This is what he did. This is T4. So in you and I, T4 is supposed to be converted to T3. At the same time, it can also be converted to what we call the reverse T3. More or less like a mirror image of the normal T3. All right. So more or less like the normal mirror image of the normal T3. So reverse T3. Look at it very well. So this is it. T3 is very active, metabolically active. Reverse T3 is not metabolically active. God is so wonderful in what he did here. So this is what happened. In a situation where the body actually needs more of T3, more of T3 will be produced. If the body does not really need T3, more of reverse T3 will be produced. So under which condition do we now have this? Okay, someone that is very sick is in ICU. This is someone that is in ICU. Very sick. Very, very sick. If the level of T3 is high, this is someone that they are even begging to feed, to really eat, or they are trying to manage to feed the patient. And the body is still now producing high level of T3. What you will see is that the patient is just shrinking in bed. For that not to happen, what will happen is what we call low T3 syndrome. This is someone that is sick. You just realize that there will be a shift in the breakdown or the conversion of T4 it will now start being converted to reverse T3. So when you check the level of T3 in that patient in bed in ICU, the T3 will be low. When you check the level of reverse T3, it's most likely going to be high. And that is low T3 syndrome. The another place where you can see this being tested is actually someone that is on glucocorticoid. Glucocorticoid can actually inhibit 5-deiodinase. So which means T4 conversion to T3 will be reduced. T4 will now can start being converted to reverse T3. So low T3 syndrome. Low T3 syndrome. So that's why you call it Euthyroid 6 syndrome. Anyways, so that's just by the way about this. Okay. So please watch out for this. It's a table question. It's going to be a table question for step 1 and step 2. So when you see it, you won't say that, no, I don't know. You know, you just don't know. This is Euthyroid 6 syndrome. You can see low T3 syndrome. So severe acute illness, ICU admission, high dose glucocorticoid therapy. So you can see, what are you going to see in the early phase? Low T3, normal TSH, normal T4, low T3. So they are not making reference to the reverse T3 here because these are the main hormone that you focus on anytime you do thyroid function test. So you just realize that the T3 is low, but the others are normal. You call it low T3 syndrome. Is the name not speaking for itself? Later, the T3 will be low, TSH will be low, T4 will be low. All of them will now be low. This is a late manifestation. What is the management? Whenever you see this, don't bother to do much. Treat the patient. When the patient is well treated and the patient is now okay, you will see the body will go back to the way it's supposed to be. And that's all. Before you start shouting, I want to give the patient T3. No, you don't need that. Just establish that it's a low T3 syndrome. You don't need to give anything. And that's another important concept here that you can see in the exam. The next important concept is what I call it significance of thyroglobulin. Significance of thyroglobulin. But Festus, you said we shouldn't really bother ourselves with all these thyroid physiology and the like. Yes, but you can still pick one molecule, at least thyroglobulin. This is thyroglobulin. This is how you will be thinking in the exam when you are reading the question. And I want you to pay attention to it. So look at the simple illustration I want to show you here. So this is the follicle. So we have T3 in it, T4 in it. Permit me to just represent it like this. We have the thyroglobulin in it. So we have thyroglobulin T3, T4. So in a situation where the patient has hyperthyroidism, so you can see this follicle, the follicular cells actually just releasing more of, I mean to just represent like this, more of T3 and T4. They will just be releasing more of them. T3, T4, T3, T4. Say this patient has hyperthyroidism. So another thing that can occur is if this cell actually dies. This thyroglobulin, this T3, this T4. So this cell lies, it dies. So what you will see, we are going to see T3 level will be high, T4 level will be high, thyroglobulin will also spill out. Now relax. What is the significance of thyroglobulin in the exam? You check the question. They are making reference to the fact that the antithyroglobulin level is very high, blah, 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 and the likes. Most likely you are dealing with thyroiditis. Thyroiditis, where you see the lysis of most of these things. You are not expecting the thyroglobulin level to be high in any other form of hyperthyroidism. So when you see hyperthyroidism and you see that the level of the thyroglobulin is actually quite high, you are most likely dealing with thyroiditis. 1 minute, please. Let me quickly show you something to buttress the point. 1 minute, please. All right. So you see this one. So please just help me pay attention to this. So you see, they just give you thyroglobulin level in the exam. I saw thyroglobulin. Immediately you see thyroglobulin there, just know you are most likely dealing with thyroiditis. Most likely. It's because the thyroglobulin is not really supposed to spill out into the blood like that. So when you see the level in the blood is now quite high, so most likely the cell is lysing, so it's not spilling out. You say most likely I'm dealing with thyroiditis. Can you see? So very easy. So when someone else read that question and that person is saying this high level of the thyroid hormone in this patient is related to what do we call it? Let me say grave disease. Permit me to just say it's grave disease. Is this? And you see, you realize that there are a lot of lies is going on here. You say, what do you see? What do you see? What do you see? So see the thyroglobulin now. The level in this is high. Most likely I'm dealing with thyroiditis. You will just flip through the option and see thyroiditis there. You pick it as your answer. Just with a concept. Can you see? Just pick it and you are okay. When you check the thyroglobulin is low, most likely the patient is taking exogenous thyroid hormone. So you see the level is going to be low. So this is just by the way for step 2 that you can actually bring here anyway. So very simple concept. So you can look at it like this. You don't need to be perfect. You just need to have a way of thinking. So there is nothing difficult about this. All right. So that's just that. So when you read the question and you see them mentioning all those stuff, if you remember this day, try to reason it out. You will smile and you will be very happy. All right. So that's just by the way. There is also what we call Wolf-Chaikoff effect. God is so wonderful. So anytime there is a sudden exposure to iodine, normally, when there is a lot of iodine, the thyroid gland is supposed to quickly pick them and start producing the thyroid hormone and flood the system with thyroid hormone. But we realize that what happens is that the thyroid gland is actually going to turn itself off. It's going to turn itself off when the thyroid gland is suddenly exposed to excess iodine. You call that Wolf-Chaikoff effect. I can't remember Wolf. I can't remember Kai. But you can try to remember Hoff. When you get into the exam, you look at the name, you see the one that contains Hoff. And you pick it. That's the answer. The child can't go and put first off effect. It doesn't make sense. You will know you've seen Wolf-Chaikoff effect, Wolf-Chaikoff before when you see it. You shall remember the Hoff. That's the main point. Once you can remember that, when you get into the exam, you will smile. And that's that. So the scenario, you can also imagine it. It's a protective autoregulatory effect. Because if you give the patient a solution that contains high level of iodine, the thyroid gland is supposed to just quickly pick them, produce thyroid hormone, flood the system with those hormone. So the patient will not be fine. Do you get it? So the patient will just be in hyperthyroidic state. You don't want that. So what the thyroid does is to turn itself off by what we call Wolf-Chaikoff effect. So the wolf is not what you are taking into the exam. The kike is not what you are taking into the exam. It is the off you are taking there. Just off. Think simply. Don't be carried away by big name. No one is going to give you grade for you cramming unnecessary jargons. Then you come down to the function of thyroid hormone. We have 7 B's But how many of these 7 B's can you remember in the exam? Yes, when you are actually preparing, it looks exciting. It is not how it is. I want to know this. I want to know this. All because you are solving question on this and that. Yeah. You just come on. You hardly remember them all. If I thought you remember at all, maybe 2 or 3. The remaining you may not even remember them. So be realistic. Now ask yourself, what are they going to be giving? Most likely, at least pick 1 or 2 and move on. Let's do that. You can't go into the exam and say, Lagbaja, Mo Lagbaja, I choose to forget brain maturation. You must be a comedian. For thyroid hormone, what will you say you are thinking? You left brain maturation? Brain maturation of all? It's not done. It's not allowed. It's not allowed. Congenital hypothyroidism is a joke to you. It's not allowed. Brain maturation. Brain maturation. Brain maturation. Never forget this. Even in psychiatry, we also pay attention to it. The next important one you don't want to forget is the effect of the thyroid hormone on the heart. You see, they increase beta-1 receptor activity, expression in the heart. So, which means that when a patient is having high level of thyroid hormone, you see, you will be seeing increase in beta-1 receptor expression. And what will the beta-1 do? Cardiac output, contractility, heart rate, all those stuff, they are going to rise. So beta blockers can alleviate this. So the question is now, what kind of beta blocker are we now going to give to this patient? So we can actually give a beta blocker that is not really, that is not just going to act on the heart alone. So you see us commonly picking something like, what do you call it? Propranolol and the likes. All right, so that's just by the way. So never forget this at all, beta blocker. So the next important point you don't want to leave out is this basal metabolic rate increasing. Basal metabolic rate. So, and this is increasing in the name of increase in the sodium potassium ATPase. The expression of sodium potassium ATPase will be high, and the next thing you see is the basal metabolic rate will be high. So most likely going to be tested. Now, if I say most likely, it means that at least if I thought you are going to forget anything, still try to pick this. They don't need to test it, but at least you see it, you will remember. That's what it means. Compared to us not emphasizing anything here, you are going to just go and forget everything. You don't need that. So remember this, sodium potassium ATPase increasing, beta-1 receptor expression also increasing. All right. What about the regulation? So this is just a simple picture you can think about by yourself. Follicular cell. I can stimulate follicular cell in 2 ways. I can stimulate it via the thyroid stimulating hormone TSH. I can also stimulate it using this TSH, thyroid stimulating immunoglobulin. Can you see the 2 ways you are stimulating it? Any question you read and they tell you that the TSH is present, positive, in that patient, most likely you are dealing with grave disease. That's your diagnosis. So it is the TSH, those immunoglobulin, that are actually stimulating the follicular cells. The TSH, they are the ones stimulating the follicular cells. Grave disease. So once you read the question and they mention the TSH there, positive and the likes, just say to yourself that most likely you are dealing with grave disease. Any other thing you want to remember or take into the exam? Yes, there is one more. And what is that? The significance of tyrosine binding globulin. You can't choose to forget it. And I'm not just making mouth. It is just the point. You can't forget it. Tyrosine, the concept around it. All right. So what is this? Anytime you remember, we used to look at hormone and say total is equal to the bound plus free. That's how we look at the hormones. We just say bound plus free. Okay. We have tyrosine binding globulin. All right. So what this does is just to bind to those thyroid hormone. Can you see? It's just to bind to the thyroid hormone. So what is going to happen is that the bound level is going to rise. Can you see? The bound level is going to rise. All because you have high level of tyrosine binding globulin in that patient. The bound will now rise. What else will happen? If the bound is rising, the total will also rise. Total is bound plus free. The question is, what now happened to free? The free is normal. It's a table question. The free is normal. It's going to remain normal. It may initially drop, but the body will replace it. It will just be normal. That is the question. This is just the question. Now, the question is, wait, what can make the tyrosine binding globulin to now be high? Forget estrogen at your own risk. Say to yourself, I, Lagbaja, Omo Lagbaja, I choose to forget estrogen because I'm a comedian. But let it shall be in the statement anyway, so you will know why you forget estrogen. The question now is, under which condition will estrogen level be high? Is this patient taking estrogen-containing pills? Is this patient producing estrogen? Is this patient having estrogen-releasing tumor? Is this patient pregnant? Any situation they give you, look for, is that situation increasing the level of estrogen? Estrogen, high level of estrogen will make the TBG, tyrosine binding globulin, to be high. That is the reason why. This is the question. This so patient is pregnant, and the patient, with further analysis and evaluation and the likes, they realize that the total thyroid hormone is high. Bound level is high, but the free is normal. The free is normal. So you see, in USMLE step 2, what they will ask here is, what do you want to do? Nothing. We know you are eager to do something, but please don't shall do anything. Just leave the patient. It is physiological. It's normal. Throughout pregnancy, estrogen level rises. Throughout pregnancy, estrogen will keep on rising. Therefore, the TBG level will be high. And the next thing you see, the bound form will be high. Total will be high. But the main one you focus on is the free. Hope the free is normal. They say it's normal. Then you don't have any headache. You just reassure the patient and say, don't worry, you are fine. Under which condition can the TBG be reduced? Is there anything making this patient to lose protein in the name of TBG2? Nephrotic syndrome, steroid use, and the likes. Think about it. And that's how this one will be tested in the exam. So the TBG level is going to drop here. You see the total is dropping, but the free is still most likely going to remain normal. You don't need to cram this. Don't give yourself unnecessary headache. Then you come to parathyroid hormone. Parathyroid hormone. Okay. So what's the parathyroid? The parathyroid hormone is actually produced by the parathyroid gland, the chief cells of the parathyroid gland. They are the main cells. So they were going to produce the parathyroid hormone. So how does the parathyroid hormone work? So parathyroid hormone has a way of working through vitamin D. You remember, parathyroid hormone will first of all, once the level is high, it will go to the kidney and say, Mr. Renal System. You say, yes, Mr. Parathyroid hormone. yeah, I'm here now. I realized that. He said, why are you here? He said, you already know that when the level of calcium in the body, in the blood is low, or that bastard called phosphate is high, I always, I'm irritated. I will be released. So that's why I'm actually released here. So the kidney will now say, so what do you want me to do? So I just want you to help me activate most of the, some of this vitamin D. Convert them from inactive form to active form for me, so I can send the active one an errand. So the active vitamin D will now go to the GI. It's going to cause reabsorption of calcium, reabsorption of phosphate. It's going to go to the bone and cause bone or release calcium and phosphate. So vitamin D does not select. It raises both calcium and phosphate. So parathyroid hormone will face vitamin D and say, it's only calcium I need. Phosphate irritates me. And vitamin D, I hear vitamin D saying that, I can't separate them. You also can throw out phosphate by yourself. But I've brought before you this day, Mr. Calcium and phosphate. Do what you like. So the parathyroid hormone will now come to the kidney and throw out phosphate. At what level? Proximal convoluted tubule. Reabsorb calcium. At what level? Distal convoluted tubule. Kai, how will I remember? You don't need to give yourself a headache. All you need to do is to write calcium starts with letter C. Phosphate starts with letter P. The next letter after C is D. The phosphate, P, PP. So phosphate is actually supposed to be reabsorbed at the proximal convoluted tubule. Calcium is supposed to be reabsorbed at the distal convoluted tubule. So what the parathyroid hormone will now do is that it's going to favor the reabsorption of calcium at the distal convoluted tubule and reduce the reabsorption of phosphate at proximal convoluted tubule. So that is why we call the parathyroid hormone phosphate trashing hormone. It throws out phosphate. Can you see? Very easy and straightforward. Okay, I got that. The next question is, Festus, what else are they likely going to ask me? Yes, there is one question you are expecting here. It's a table question. That's why we put an arrow on it. It's a table question. So how will the question look like? They know you know. They know you have been hunting for stuff here and there. All right. They will tell you that the patient has maybe high level of calcium, blah, 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 and the line. They will just give, parathyroid hormone. They will now say, what do you think will happen to the level of calcium, serum calcium? What do you think will happen to the level of phosphate? What do you think will happen to the level of urinary phosphate, serum phosphate? What do you think will happen to the level of serum phosphate? What do you think will happen to the level of urinary phosphate? What do you think will happen to the level of urinary CAMP? Expect it in the exam. Very easy. So you just say, parathyroid hormone is going to end up raising the level of serum calcium. There is one more we should add to it. Let's add it. Let's call this. I want you to get the gist. So let's call this urinary calcium, serum calcium. All right, can you see? Urinary calcium, serum calcium is a table. If I thought they would give anything, it won't go beyond this. Anyhow, they now want to cut it, let them cut it. So you now say to yourself and be like, you need to be calm. If you are not calm, you will not know you actually know it. Parathyroid hormone is supposed to actually reabsorb calcium into the blood from the, distal convoluted tubule. So if it's reabsorbing calcium, it shows that urinary calcium will actually drop. Serum calcium will now be rising. Can you see? Then it's supposed to throw out most of those phosphate into the urine. Serum phosphate level will drop. Urinary phosphate will rise. The second messenger that actually characterize the function of the parathyroid hormone is cyclic AMP. The level will be high in the urine. High. Shikena. Can you see how you determine your stuff? So you just need to relax and think. Then you pick. There's nothing difficult about it. Once you know the function of parathyroid hormone, you just realize that, okay, this actually makes sense. Okay, that's that. The next important concept here that you don't want to forget is about the osteoblast, the osteoclast. All right. They will ask you in the exam. I'm very sure you will have been seeing rank ligand and rank. Okay. Ligand means something that binds. That's a ligand. Something that is released that will go somewhere to bind. All right. So now we have the osteoclast. We have the osteoblast. Osteoclast. When I say, you say Festus is blasting that guy, then definitely I am the one talking. You are this, you are that, blah, blah. Why are you blasting? I blasted him. I'm the one talking. In what language is the Festus talking? Festus is talking in rank language. It means osteoblast is the one that will release rank ligand. What is that hormone that will stimulate the osteoblast? It is actually the parathyroid hormone, PTH. Out of these two, PTH is actually the one that has the receptor for parathyroid hormone. Osteoclast does not have it. Don't go and fall for that trap in the exam. Parathyroid hormone will bind to the osteoblast. Osteoblast will start blasting in rank language. So it's now going to start releasing rank ligand. Rank ligand. Can you see? Rank ligand. Can you see? Rank ligand. So this rank ligand will now come to rank. Can you see the rank? They will now be binding to the rank. So which of these cells has rank receptor? The one that is receiving the blast anyways. And this is osteoclast. You see, the guy needed to class himself when he was blasted. Osteoclast. So this is the rank ligand. This is the rank. So osteoclast express rank. Can you see? Which is more or less like, so why the osteoblast releases rank ligand? Very easy. So which of them has receptor for osteoblast? For PTH, osteoblast. Can you see? Very easy. There is now a concept here. You call it the concept of osteoprotegerine. Osteoprotegerine. God is so wonderful. So there is another protein that can actually be released by the osteoblast. You call it osteoprotegerine. What will osteoprotegerine do? You call it's actually more or less like a rank ligand decoy. It's a decoy. It's not actually the rank ligand. It's just a decoy of it. So what does that mean? It means that if this is what the body will do, let me assume that this is now the the osteoprotegerine. If you look at it, it looks like the rank ligand. If it comes and it binds to the rank, nothing will happen. Nothing will happen. Can you see? It's not going to do anything. So it's a decoy. So what the body does is that if the body wants to, this is how the question will now come. It's now more or less like a ratio of the rank ligand to the osteoprotegerine. So in a situation where you want the osteoclast to be highly active, then the body needs to release more of rank ligand. in a situation where we don't want the osteoclast to be active, we are going to release more of osteoprotegerine. Shakener. So you can look at the ratio given in the exam. Think and you pick the answer. It's just a qualitative reasoning. Look at the ratio. Which one is more? If this one is more, then the osteoclast will be active. If this one is less, then the osteoclast will not be active. Just look at it. And that's all. The last but not the least is about the parathyroid hormone related peptide. You think it's just a joke for them to call it the hormone PTH related peptide. It shows that they all belong to roughly the same, they act in the same way. The function is roughly the same, but they are not released under the same condition. Parathyroid hormone related peptide becomes the order of the day if you are seeing hypercalcemia in a patient with squamous cell carcinoma or renal cell carcinoma. Malignancy, usually squamous cell carcinoma of the lung, renal cell carcinoma. You now see hypercalcemia, then now say, what do you think is causing it? The answer is parathyroid hormone related peptide. The level of parathyroid hormone may even be low in them. So this hypercalcemia you see here has nothing to do with the pure parathyroid hormone. It's all about parathyroid, and that is just the question. They will just show you someone with squamous cell carcinoma of the lung that is having hypercalcemia. They will just say that which of the following is the likely cause, or which of the following molecule is likely responsible, or something like that. Just flip and just be looking for PTH related peptide, PTH half-pay. I'm going to peg that one there and allow us to go for a break of 20 minutes. All right, so when we come back from break, okay, before we go for a break, let me quickly, so I will know I've left this page. So we come back from break and continue from the next page. The next important point is about, basically the summary here is about what are the causes of hypomagnesemia. How come it's hypomagnesemia we are bringing out here? Very, very easy concept and very, very important. Magnesium is an underdog responsible for most of the manifestations you see that are related to some of the other electrolytes. Someone that is having hypokalemia, they say we correct it, it's not corrected. And go and check the magnesium. Maybe the magnesium is low. So you can't joke with magnesium in the exam. And this is how I put an arrow on alcohol use disorder, most tested concept. Just as this patient has hypomagnesemia, they will now give the story. They will have given the story, they will give the magnesium. You see that his magnesium is actually low. So you ask which of the following is most likely responsible for the observed effect or something like that. Most likely going to be alcohol. Maybe the patient has alcohol use disorder. This is someone that takes alcohol and the likes. So they will have spelled it out loudly. So you will have seen it and be like, oh, this makes sense. So you don't want to forget that alcohol use disorder can actually cause hypomagnesemia. Another one is aminoglycoside, diuretic, then diarrhea. You call it DAD. So if you can remember that, fine. If you can't remember that, ignore, you shall remember alcohol use disorder. The last point here is about the calcium homeostasis. So what happens in calcium homeostasis? There are two guys that are competing to bind to albumin. So this is the albumin. This is calcium. This is hydrogen ion. So in a situation where the hydrogen ion is actually high in the blood, more hydrogen ion will be binding to the albumin. So the calcium will now be left free, unbound. So therefore, the patient will develop hypercalcemia. How will this one now be? How are they going to link it up? They will just tell you, give you a scenario where the patient has acidosis. If the patient has acidosis, more hydrogen ion will exist in the system, will be binding to the albumin. So most of this calcium will not be binding. They will now exist free. So there will be a spurious belief that the free calcium is actually high. If the calcium level is high, parathyroid hormone will not be released. So therefore, PTH release will be reduced. Parathyroid hormone level will now be low PTH. Another concept is a situation where you are dealing with alkalosis. Alkalosis. The way they will portray it, look at the question, it will be there. You will shall know that this patient has alkalosis. They will now be relating it to the calcium release. The parathyroid hormone release. So you now say, if this is alkalosis, hydrogen ion will be low. So most of the calcium will be binding to the albumin instead of hydrogen ion. Therefore, the level of free calcium will drop. And low level of calcium normally stimulate the parathyroid gland to release parathyroid hormone. Therefore, parathyroid hormone level will rise. And that is why we put it in a box that we know you are busy. But the concept here is easy. Please try to note it. So you just note it. So can you see? High pH. High pH means low hydrogen ion. Don't go and fall for the trap. Anyone can make the mistake. High pH means low hydrogen ion. So which means that more of the calcium will be binding. So the level of free calcium will now fall. Low level of calcium will now be stimulating the parathyroid to actually release parathyroid hormone. That's why you see increased level of parathyroid hormone. So what are the symptoms, manifestation of low level of calcium? Cramps, pains, paresthesia, carpopedal spasm. Very easy. The same thing for this one. And that's that. The last one here. The last one is the calcitonin. Calcitonin. You already know where the calcitonin is coming from. Parafollicular cells of the thyroid. And if I thought they ask you, what is the origin of parafollicular cell? Never forget that. Neural crest cells that actually migrate to the bed. You say which bed? Ophthalmobrachial body. Yes. Where is the ophthalmobrachial body coming from? You remember? So pharyngeal pouch. Okay, so that's just by the way. So calcitonin is not, just for you to have an idea about it anyways. So it's actually released when the level of calcium is high. Let me clean this. So that's when it's released. Parathyroid hormone is released when the level of calcium is actually low. So calcitonin is the one that is released when the level of calcium is high. So it's released to tone down the level of calcium. So you can see it's opposing the action of parathyroid hormone. It's not important in normal calcium homeostasis. In case someone is going for the exam and you are shouting, you will be tested. So it doesn't mean they can't test it, but the possibility is low. So it's not something that is important. So I'm going to stop here for now. You can go on break of like the next 30 minutes. So after break, so according to my screen here, so we come back by 2:40. Permit me to use that, 2:40. So let's enjoy our break. Thank you. All right. So before we continue, I will just quickly introduce you again to the concept. So I don't think the meeting today will make any sense if at all you don't know who we are, what we stand for. So we are actually the Concept Academy. So what we do is actually to lift off that headache of USMLE preparation. We are not saying you can't prepare by yourself. Sincerely speaking, you can actually do it. So you are all we are actually standing for is to make that your preparation quite faster. No one is saying that you can't read first aid. No one is saying you cannot solve questions. No one is saying you don't know most of these things. But when you hear it from our own mouth too, so then you will be rest assured that okay, you are most likely doing the right thing. Then people are very, very busy. So because of that busy schedule, they find the USMLE preparation quite long, boring, and quite unyielding in a way. So because when they go into question, they don't even know how to think. So what we do basically is just to show you the simplicity of a way to look at them, and to let you know too that it's not compulsory that you are actually perfect in everything you are doing. So our latest release is actually what we call the USMLE Rapid Review Pro for USMLE Step 1. We released it late last year, so still very valid. All right. So people just come, you just subscribe to it, and you listen to the videos basically that are there. So this is the website for you to have an idea of what is going on. So you are just expected to, when you come, so you actually need to subscribe to it. So you can subscribe for 2 weeks, which is $150. You can subscribe for 14 weeks, which is $600. But we actually bet it with you that what you are going to gain in all these stuffs, they are far beyond whichever amount of money that is there. You will even be the one saying it by yourself that what I gain, what you guys actually help me to do is far beyond whichever amount of money I drop. So that's all this $600. And so if I told you don't have $600, you can go for 6 weeks, because some people, they still have this element of doubt because they don't know us, they don't know what we stand for, how we do our things. So some people will be like, okay, let me test you for 2 weeks. You can go for any number of weeks, but whichever level of preparation you can be, so you realize that the concept we had to it for you. You can't say I regret subscribing to it for 2 weeks with them. So you can go for 4 weeks, you can go for 10 weeks. And if at all you feel that you're already doing it right, very well, you are okay, please just continue. You don't need to waste your money. So with respect to your preparation, if you can lay hands on our material, and you also have your question bank, you are just using those questions to actually more or less like rehearse. So you realize that it actually helps you and make your preparation faster. So this is one of the testimony we get. Like, okay, something that could have taken me up to a month, I end up just finishing it within a day. Within a week. So that's how the thing is going to look. So this is the curriculum. So you see, for the cardiovascular system, you just listen to 3 videos, basically. Then you get the gist of whatsoever that is going on there. For the endocrine that we are doing now, you just listen to 2 videos. For the GI, you have 4 videos to listen to. So then you have cardio, endo, mock, so that you can actually have like 44 questions just for you to just play around with. So hematology, our neuro release, you can check it. So it's going to really give you a headacheless journey. So psychiatry and all manner of stuff. So these are the things that you actually get from us. All right. So 1 minute, please. So that's actually, so the total number of videos you just need to sit down and listen to, basically, they are just more or less, you can see, even actually less than 70. So within, if you are very aggressive enough, you realize that within few, few weeks, even within 6 weeks, you can even finish everything. You can finish everything within few weeks. Sorry. So that's actually the concept. Sorry for the little break. So that's actually the concept academy for you. So a lot of people have written their exam through us. Some of them have actually got in March and the like, so not a big deal. So no matter where you are in your preparation, the headache you think you are having, give it a try. So you realize that it's actually it's actually simpler than you think. So you just don't know. It depends on who is giving you the information. So that's by the way. I'm going to continue from where we stop. And this is actually the glucagon. Glucagon is not a stranger to us. You remember, peripherally located alpha cells, they are the one that actually release the glucagon. So what the glucagon is supposed to do basically is just to raise the level of blood sugar. So that is glucagon for you. How do we actually regulate it? So this it depends. Anytime the patient actually move into the state of hypoglycemia, you see glucagon is one of the hormones that is going to be released. So it can be inhibited by insulin, amylin, somatostatin, hyperglycemia. Then you come down to Mr. Insulin. Insulin is not a stranger. Possibly someone just gave insulin today again to a patient. So what are they going to be asking about it? Very simple concept. First, tell us about how it is released. So insulin is actually released in the name of insulin and C-peptide. This is how it's released. This is how it is produced, pre-proinsulin. So it's going to pass through all manner of modification. So then it will eventually be released by all those secretory granules like insulin and C-peptide. So the quantity of the insulin and the C-peptide in a way they balanced. All right. So now this is now where you are expecting them to be hiding. So when you check your question and the question says that the level of insulin in this patient is high, the next thing you want to quickly trace in that question is, what about the C-peptide? If the question is also saying C-peptide is also high, you know that that high level of insulin is endogenously released. So most likely, maybe the patient is having insulinoma. Maybe the patient is taking insulin secretagogue. Maybe the patient is actually having type 2 DM. Once you see both of them increase, and that's just all you are looking for. You are just the one carried away by the story. You see them like, okay, insulin in this patient is high. Just be looking for any impression of the C-peptide. So in the option now, they might not say option here, the patient is having type 2 DM, insulinoma, insulin secretagogue, you at least all manner of jargons there. So what is expected of you is actually to say that, okay, go back to the question. Is this patient on any drug? So you now realize that this patient is actually on some drugs. One of them is maybe glipizide, glimepiride. You'll be like, okay, these are actually insulin secretagogue. So that is most likely what is making maybe the patient is just taking an overdose of it. And that's just what you pick as your answer. So that's how you look at it. In step 2, they love to test more of insulinoma. You see, very specific information. So it doesn't mean they can't test these others. They can test them, but they love to test the insulinoma. All right. So when you check the exam, the question, and you realize that the only one that is increased is the insulin, C-peptide is not. So your answer becomes exogenous insulin. So most likely the patient is just dosing himself with high level of insulin. That's your answer. Can you see? So insulin is synthesized in pancreas and cleared by both liver and the kidney. So in a situation where the patient is actually having kidney problem, you may actually need to adjust the dose. All right, very easy concept. Then you come to the function of insulin. I'm very sure immediately you see this area, you will have palpitation. like, I need to sit down. They say, where are you going? You say, I'm going to library. To go and do what? I need to read. I just saw insulin function. I need to sit down and cram it. Come on, get off that. You don't need to cram anything. You just need to have a way of looking at it. Because what you'll be given is scenarios in the exam. All right. So what is going on here? Insulin bind to the insulin receptor. That receptor is what we call tyrosine kinase. Acts tyrosine kinase activity rather. It has tyrosine kinase activity. Forget this at your own risk. These are one of the rare questions you may be seeing and be like, they asked me about I don't know what to pick. This is the answer. That's tyrosine kinase activity. And that's more than enough. You've already tried there. The next thing is, what are the anabolic effects of insulin? Insulin has anabolic effect. I used to say insulin builds. What does that mean? They ask you in the exam that what will the insulin do? You don't need to be thinking far and wide. You just need to be like building. It's just going to be building. So anything that is related to insulin building the body, that will be very correct. Increase glucose transport in skeletal muscle, adipose tissue, increase glycogen synthesis, increase triglyceride synthesis, increase sodium retention, increase protein synthesis, increase cellular uptake of potassium, reduce glucagon release, reduce lipolysis. Insulin builds is more than enough. It has summarized everything here. So that summarizes everything. So insulin builds. All right. And that's just a very wonderful way of looking at it. So without you giving yourself unnecessary headache. There is something we put in a box here that you just want to remember. They say, Doki? Say, yes. We know you've told us everything about this insulin. In fact, the way you were explaining it, you'd be like, thank you. You just try to summarize it. But between glucose, insulin, this thing, with respect to someone that is a diabetic mother. So how do you look at it? You see, glucose can actually move through the placenta. So that's the reason why when you look at those ones, you just realize that this is the placenta. Permit me to represent it like this. This is the baby. So this is the baby. So glucose will move through this placenta to come and meet the baby and start romancing the baby's pancreas. So the baby will start pushing a lot of insulin out. So there will be hyperinsulinemia in the baby. The next thing, what will that do? Insulin builds. So the baby will now start building. Will start becoming bigger, 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 bigger. And that is how the baby will become macrosomic. So insulin build. So how are we now going to address this patient, this mother's glucose, in such a way that this glucose level we can reduce it, so that the glucose that will be going to the baby also will be reduced? Give the mother insulin. Insulin. Just give the mother. This is the most tested drug for the gestational DM in United States Medical Licensing Examination Step 2. Insulin. So sometimes once you realize the diagnosis, you may not even really think. If you don't have the time, you may just pick it. But it doesn't mean they can't test the oral drugs. They can, actually. But this insulin, once you see it in the management, this is one of the things you don't want to joke with. Can you see the way you think? So for them, you control the diabetic mother's high glucose, you control it with insulin. All right. So when you control the insulin, then we drop. Insulin going to the baby will drop. So, the glucose in them will drop. Glucose going to the baby will drop. So the glucose stimulating the pancreas to release insulin in the baby will also drop. So the hyperinsulinemia in the baby will start falling gradually. All right. So that's just by the way. You see, it's just a very simple concept, and that's how it will be tested. So the next thing you might have been seeing in questions flying around some of those question banks, is actually something that is related to the glucose transporter. You see, you just need to be very strategic in what you know. You don't need to know it all. So if I ask you a question on glucose transporter 1, you don't know, it doesn't reduce you to anything. I ask you a question on glucose transporter 3, you don't know, it doesn't mean anything. So, but the ones you are supposed to shall remember, hope you shall remember that one. You say, yes, I know that one. You have already done more than enough, because your way of thinking will be very specific in the exam. Focus on GLUT 4 and GLUT 2. Just focus on them very well. For the GLUT 4, is related to adipose tissue, striated muscle. Can you see? There is something that actually increases the expression of this GLUT 4, and that is exercise. How come you tell patients that are diabetic to also do exercise? You tell them because exercise is going to raise the level of GLUT 4. So what do they want you to know is in which set of tissue will you see this GLUT 4? So striated adipose tissue. That's more than enough. So adipose tissue, striated muscle. All right. So the next one is the GLUT 2. GLUT 2. You know, one thing that can kill a dream is actually when you are having double standard, you are not specific enough, your dream is bidirectional, it's not focused, it killed it. GLUT 2, bidirectional, kill it. Kidney, you see it in kidney, you see it in islet cell, you see it in the liver. You can go and add GI tract to it. So you can look at it like that if you wish. At least you shall know that you remember something. So, and that's more than enough for you. You just rehearse on that over and over and over and over again. Take that into the exam you've tried. You won't be disappointed, because the possibility that they will leave GLUT 2 and be testing on GLUT 3, the possibility is very low. This is a clinical exam. All right. So, brain prefers glucose, but if I thought ketone exists under one condition or the other, like starvation, so the brain can still use the ketone. It's just a point, because you wonder how come you can still think when you are starving. All right. So, what of red blood cell? They only use glucose. They don't use they don't use ketone, because they lack mitochondria for aerobic metabolism. You see how specific you are in what you do. We just look at it like that. So the next area you come where you are expecting questions is this regulation. So let's bring out some questions here. All right. Glucose itself is actually the major regulator of insulin release. They say what determines it is the glucose. So if the level of glucose is high, insulin will be released. All right. So increase insulin response with oral versus intravenous glucose. So now this is a question you are expecting in the exam. They will test it. All right. How come you have more insulin response with respect to oral glucose compared to intravenous glucose? How come? Why? Why? That's the question they are going to be testing in the exam. Because you wonder why in endo department, they quickly want those patients to actually they quickly want them to start oral feeding instead of just giving them food through so they just want them to quickly start. You want to quickly start them on oral feeding as soon as possible. It's because of this concept. Because a patient that is taking oral that is eating orally is more likely going to have higher level of insulin compared to someone that is taking his food intravenously by one reason or the other. So what is going on? It's actually through this hormone. You call it incretin. Incretin, this is the name of the hormone. So incretin will be released so it's going to be released when the patient is actually taking the food orally. So incretin will not be released if the patient is taking the food through the intravenously or parenterally. So that's incretin. Any other name for incretin? Glucagon-like peptide. Glucose-dependent insulinotropic polypeptide. Can you see? So it's going to be released. So incretin will now go and raise the level of insulin that is actually going to be released. So that's how it. So when you look at, they can give you a graph. You can think out loud here. They will just tell you that, okay, insulin is high here. It's not really too high here. So this patient is taking food orally. This patient is taking food intravenously, something like that. They are just asking what is making the insulin to be high in the patient that is eating orally compared to the patient that is taking parenteral nutrition. So it now be like the name of the hormone they are testing is just incretin. That's how they are most likely going to test that. You can also imagine some other scenario. So just think anyhow you can think. In the exam you are going to think. That's just it. You are going inside that exam to go and think. So you just be like, okay, I think this is what is going on. So all these points we are making is just to lay foundation for your thinking, so that the way Dr. A is going to think is most likely going to be the same way Dr. B is going to think. All right, the next one point you want to take into the exam is about these receptors. So with respect to insulin release, alpha 2, beta 2. Alpha 2 generally is inhibitory. I used to say that. Inhibitory. For those that have our this thing, you learn a lot in pharmacology. So it's inhibitory, just inhibitory, which means that, so you can just look at it that if this alpha 2 is stimulated, definitely there will be a reduction in the release of insulin. So beta 2 is now going to be the opposite. So alpha 2 stimulation will reduce insulin release. Beta 2 is going to increase insulin release. Can you see the way you look at it? Just by writing alpha 2, beta 2, at least beta 2 is better. All right. So that's the next point. The next important point is about this diagram. So you can't go into the exam without understanding the way insulin is actually released. And I will show you the kind of questions you are expecting. So the way the insulin is released here. So don't forget that we're talking about some organ that actually have GLUT2 in them or on them, their cells. So one of them is actually the pancreas, islet cells. So islet cells of the pancreas. So this is actually the GLUT2. So the thing about the GLUT2 is that it is actually its own glucose transportation does not have anything to do with insulin. So that is why when you come back here, we say it's insulin independent transporter. Their expression has nothing to do with insulin. So they are just expressed. So can you see this is the islet cell? The GLUT2 is here. So the GLUT2 will just be here. Then the glucose in the patient will now move through it and now come into the cell. So what will now the glucose undergo? The glucose will undergo glycolysis. With the glycolysis, ATP will be produced. So this ATP that is produced now will now be more than ADP. So ATP level will be higher. So it means that ATP-ADP ratio will now be high because ATP is produced. So question USMLE love to test for some time is about what's the significance of this high level of ATP-ADP ratio. You will just expect it in the exam. So the significance of this is that this high energy state is going to come and actually close this it's going to come and close this potassium channel. Can you see? So this potassium channel is ATP sensitive. So once the ATP is high, the potassium channel will be closed. So as the potassium channel is closed, so potassium cannot go out. So the cell membrane is now going to be depolarized. Can you see? It's going to be depolarized. All right. So that depolarization is now what is going to open the voltage-gated calcium channel. This is voltage-gated calcium channel. So as it opens, calcium will just flood into the into the islet cell. And the calcium has one wonderful role. They help to move the vesicles. So they will now move the vesicles containing those insulin. They will move them towards the membrane. The vesicles will fuse with the membrane and now release the insulin out. So insulin will now be released into the blood and be carried everywhere. So now, that's how the insulin is released. So if I thought you are going to rehearse this, ask yourself, stand before the mirror, say it. I lagbaja omo lagbaja. When I get into the exam and they give me something about this, I promise not to forget the significance of ATP in the depolarization of the cell. So help me God. Bam. You just like make joke around it in a way. And as you are also doing that, your brain is picking it, because most of those stuff you will remember when you are doing them. All right, so that's about this. And never forget how it's blocking this potassium channel. So those are the things you are expecting here. So insulin is now in the blood. It will now come to this insulin dependent glucose transporter related tissue. One of them is actually the striated muscle. So you can see insulin will now bind to the insulin receptor. As it's binding to the insulin receptor, that one has tyrosine kinase activity. So you can see with that kinase activity is going to phosphorylate all manner of important protein. So those proteins that are actually going to be phosphorylated, so they are now the one that will now facilitate most of the other things you see, like glycogen synthesis, lipid synthesis, protein synthesis, and the likes. And that's just that. So can you see what we emphasize here? Can you see how you link it to tyrosine kinase? So these are the things you are taking into the exam. You come down to the adrenal steroid and congenital adrenal hyperplasia. The first question you want to ask yourself is that, how come the adrenal need to become hyperplastic? What is making the adrenal to actually be hyperplastic? That's the question. What is hyperplasia? Just the multiplication of those cells. How come the adrenal is actually becoming hyperplastic? This is it. In all of them, they actually have reduced level of cortisol. Reduced level. I'm still on the name. Reduced level of cortisol. So that reduced level of cortisol will make the negative feedback on the pituitary with respect to the release of ACTH to be reduced. So therefore, ACTH level will now be high. That high level of ACTH is what will constantly now be stimulating the adrenal. Will now be stimulating the adrenal gland, the cortex. And the next thing you start seeing is that there is hyperplasia. So that is congenital adrenal hyperplasia. Just for you to have an idea where the hyperplasia is actually coming from. So in all of them, the cortisol level is going to be low. Thank you, Festus. Yeah, you are welcome. So now, show us how we are going to cram this table. Sorry to disappoint you. You don't need to cram the table. USMLE has little regard for cramming. You can pass over by cramming because you are used to it, but you don't know. You want to be able to look, you think, and you pick. You call, or what is going to guarantee that is concept. Just understand the concept. You don't need this table at all. It's only if I thought you are a lecturer or you teach, you want to show the medical students, then you can be cramming this and maybe you can be drawing the table for them. You as a clinician, you don't need to cram this table. You don't need it. Sorry to disappoint you. So how are you going to be looking at it? Very simple concept. So, you see, this, you can start with this pregnenolone. You don't need to remember pregnenolone, but just for you to have an idea that there is a particular molecule where you want to start your analysis from, how you are going to be looking at the question. So this pregnenolone, progesterone, pregnenolone will give birth to progesterone. Pregnenolone itself is coming from cholesterol. So they just say, okay, pregnenolone is actually going to give birth to a particular molecule. You call that molecule 17-hydroxyprogesterone. The enzyme I will need to generate this 17-hydroxypregnenolone. 17-hydroxypregnenolone is actually 17-alpha hydroxylase. Dr. Festus? I say yes. Sorry, but you say we shouldn't really note the molecule. I say yes, I still maintain it. You don't need to note the molecule. Because in the exam, the name will be given to you. What you need is just a clincher to identify them. So the clincher you will use to identify this is just the number 17. Number 17. So you look at these guys as precursors towards what you call the androgens. Now they relax. You are reading the question. You just see 17 hydroxy something. Once you see that number 7, just say it's a precursor towards androgen. Because the guy is already at the age of 17. He's already becoming a big boy. He's already becoming a big girl. You can look at it and just make a joke. So you're already having a high level of androgen. You're already pursuing some other genders. And like, you just laugh. 17 hydroxy. 17. We shall put 17 there. So it's not for you to be like, hey, what's the name? It will be given. Just remember the number 17 is going towards the androgens. Can you see? What are those androgens? Dihydroepi, androsterone. At least you will say andro in the name. Androgen. Andro, still dione. Androgen. What else do you want? Is it testosterone they will write that you will say you don't know is an androgen? No, now these are the ones they can write. You can say I don't know is an androgen, but andro is in the name. Andro. And these are androgens. 17 hydroxy something. We go to androgens. All right. The next one is these same molecules. Pregnane, progesterone, pregnenolone. They can also be channeled to mineralocorticoid. They can be channeled to mineralocorticoid. They can be channeled to mineralocorticoid. These androgen can be channeled to the cortisol. All right, now relax. So this is now how you are going to be looking at. You are going to be drawing two axes in your exam. So this is the thinking. This is the thinking. So we have the precursor here. Please focus on what I'm trying to show you. That precursor can go like this to give you androgen. So you need 17 alpha. Can you see? Hydroxylase. All right. This precursor can also come and be converted to mineralocorticoid. Mineralocorticoid and also cortisol. So because the cortisol in all of them is low, you can actually just disregard this cortisol and just say that mineralocorticoid. So like those mineralocorticoids. So the level will just go down in them. That's a very good one, like aldosterone. So the level will just be, so they can be manipulating the level in the exam. All right. So what are the enzymes that are just related to this? The enzyme, there are two you focus on. The first one is 21. The second one is 11. Please, I want you to pay attention to what I'm saying. The first one is 21. See what I'm drawing you. The precursor is here, can go like this, give rise to androgen. The precursor is here, can come down and give rise to this mineralocorticoid, also cortisol. That's fine. The two enzymes you have that are related to this fatty cool acids, they are 21 hydroxylase, also 11 hydroxylase. You can look at it like that. 11 beta hydroxylase, that's fine. In between 21 and 11, there is a precursor that will be produced. That precursor that is produced is 11 deoxy. 11 deoxy. Deoxy will be produced. 11 deoxy 11-deoxycorticosterone, 11-deoxycortisol. You don't need to know the full name. Just shall remember 11-deoxy something. That's all you need. Now look at it. If 21 hydroxylase is present, it shows that 11-deoxy will be produced. If 11 beta hydroxylase is absent, it means the 11-deoxy will accumulate. Look at it. Don't mind what I'm saying. Look at it. If 21 hydroxylase is absent, 11-deoxy will not be produced. If 21 hydroxylase is present, 11-deoxy will be produced. If 11 beta hydroxylase is present, 11-deoxy will be converted. If 11 beta hydroxylase is absent, 11-deoxy will accumulate. So now, they now give you a question. So now, before I give you the scenario, this is now what happens. If the enzyme on the horizontal is deficient, the enzyme on the vertical will be hyperactive. If the enzyme on the vertical is deficient, any of them is deficient, the one on the horizontal will be hyperactive. What does that mean? If this patient is 21 hydroxylase deficient or 11 beta hydroxylase deficient, there will be hyperactivity of this 11 alpha hydroxylase. So a lot of androgen will be produced, first of all. What does that mean? You read a question and you are seeing hyperandrogenism in the question. They say the level of 17, something, 17 hydroxy something is high. You just say that it's either you are dealing with 21 hydroxylase deficiency or 11 beta hydroxylase deficiency. The only thing you sketch in the exam is just this this graph. Just write X and you just put your arrow and put 17 alpha here. You know that one will be going towards androgen. You now put 21 and 11. At least 21, then come down 11. The number is decreasing downward. 17 is here. 21 is here. 11 is here. 1, 7, 2, 1, 1, 1. All right. The number is decreasing. So if the question says there is high level of androgen, just know any of these two is deficient. The next question is, you now check that question to look for this 11-deoxy and say, is it high or low? This is a qualitative reasoning you give to primary 2. You just explain this. They will be telling you this one is deficient. This one is, because you just need to look and think. You just say, this patient has elevated level of 11-deoxy. Then my answer is going to be 11 beta hydroxylase deficiency. This patient is having maybe something that like normal level of deoxy or something like that, or reduced level of deoxy. I wanted to say reduced level of deoxy. You just say 21 hydroxylase is deficient. Can you see the way you look at it? If 21 is deficient, 11 deoxy will not be formed, so the level will drop. If 11 beta hydroxylase is the one deficient, 11 deoxy will accumulate, is not converted. Can you see? 11 deoxy kini. You say, I don't know, but I will just shall look at the options and just look for those 11, anyone that is there. So now look at it. So you can bring this to 17 alpha hydroxylase deficiency here. You now come to your table and now say, okay, 17 alpha is deficient here. Then the activity of these ones will be very high. So mineralocorticoid level will be high. Can you see? Cortisol is still what? Is still low. Androgen will be low because 17 alpha is actually what? Deficient. So how will the patient present? Look at their table. So this is the table now. So mineralocorticoid is high. Can you see? Because this is the enzyme that is 17 alpha is the one that is deficient. Mineralocorticoid will be high. A lot of them, because the activity of this enzyme will rise. Okay. Once the mineralocorticoid is high, BP will rise. Potassium will be low because aldosterone or mineralocorticoid will throw out potassium and reabsorb sodium. In all of them, cortisol is low. What of androgen, which is sex hormone? You say the androgen is going to be low. So the androgen is low here. Can you see the way you look at it? And that's that. So they can give you this androgen, which is fine. That's very okay. So when you check the blood, those androgen, the level will shall be down. Androstenedione, the level will be down. How will the patient present? Which of the two gender is supposed to have androgen? They say, you need for the male, we need the androgen in them very well. So when you check that male child, the male child is most likely to have atypical genitalia. Atypical genitalia, undescended testes, because the androgen that should facilitate all those stuff is not there. What of the female gender? So they are just going to lack the secondary sexual characteristic, because as they are small, majority of their estrogen is basically coming from the adrenal gland. So, and those estrogen, they are produced from the androgen. So estrogen in them will be low because they are also lacking androgen. So they will now lack secondary sexual characteristic, but they will still pick up later. Do you get it? When the estrogen from the ovary starts helping out. Can you see the way you look at it? What of 21 hydroxylase? You just come to your table again. You don't need to cram it. You can draw it by yourself and just be doing the thinking. So if the 21 hydroxylase is deficient, you just say this one is deficient. So first of all, because one of the enzyme on the vertical is deficient, this one will take over. Will be converting most of this precursor. So I will have the patient will have a lot of androgen in the system. That's number one. So androgen will be very high. The second thing is that the level of 11-DOC will be low because 11-DOC will not be formed. I will now come back to this area. So 11-DOC corticosterone, which is a weak mineralocorticoid. So which means that the mineralocorticoid level will drop. Can you see? The level is low. So potassium is not excreted. So potassium level is high. BP, sodium is not reabsorbed. BP is going to be low. Coupled with the fact that cortisol is also low. It's also going to make the BP to be low. A lot of androgens are produced. You can say androgen is very high in this patient. So when you check the level and you are seeing 17 hydroxy progesterone, you see it's going to be very high. So these are the precursors for androgens. You see, they will just mention this is one of the molecules they test a lot in step 2. This 17 hydroxy progesterone. So when you listen to our stuff, you see the way we break it down and solve a lot of questions with you. All right. So definitely this patient has a lot of androgen. You now look at the gender in that question and now say, is this patient a male? They say the patient is a male. Maybe androgen is needed in a male. You now say, the level is too high. You say, the level is too high. So what that male child will now be having at the age 4, age 3 is already growing bare. Precocious puberty. Permit us to just put it like that. Precocious. Just be seeing something related to precocious puberty in the patient. What of the female? The female are also, they can have androgen that can easily be converted to estrogen, but not too much. So you now be seeing the patient, the female child will now be looking like a male because androgen is too much in them. So you call that virilization. When you virilize a male, he's looking more like, a female is looking more like male. That is virilization, XX. So you make reference to virilization, most especially when you are making reference to a female. And that's just that. Can you see the way you break it down? Come to 11-beta hydroxylase deficiency. So you just come here too. You now say, okay, if 11-beta is deficient, definitely 17-alpha activity will be high. A lot of androgen will be produced. Then 11-DOC. Can you see? 11-DOC is now going to be accumulating. Can you see? The level of 11, when you check the question, you will see elevated level of 11-DOC in that question. So that just give it, I just realized that 11-beta hydroxylase is deficient. So you can see 11-DOC corticosterone is high. All you need to do is just to sketch that single thing and you will just be answering questions. So you can see that you can now extrapolate your table. All this, when the deficient enzyme is this, and you may not really need all those stuff. No matter how complex the question may be, you realize that you're actually just answering them. So, I never even opened any question for you. But basically, you realize what we do in all our material, the one I showed you, is that when we show you those concepts, we are not going to answer all these questions like this for you. You see and be like, oh, this actually makes sense. You'll be able to apply. Let me show you a typical example just for you to see the way you apply that in the exam. You need to take your time to read the question. You say an infant is born. You don't need to have stuff here. No stuff. is born at 39-week gestation to a 26-year-old woman. You say yes. This is not the first time someone will be giving birth now. The delivery was uncomplicated. And APGAR scores were 8 and 9 at 1 and 5 minutes. So yeah, this is good. So the mother had gestational diabetes during pregnancy, which was controlled by diet alone. Physical examination of the infant showed clitoromegaly, which means that the clitoris is now big, like a mini phallus. All right. So then partial fusion of the labioscrotal fold. So the labioscrotal fold is not fusing the way it should fuse to actually form the scrotum. So you are just seeing the partial fusion there. You just be noting all those features. They now say, is this patient, that's the next question, am I dealing with a male or a female? They now say, okay, cytogenetic analysis reveal a karyotype of 46XX. They now say, oh, this child actually is a female. Can you see? The child is actually a female. Okay, so it means that for me to be seeing clitoromegaly partial fusion, it shows that the child has a lot of androgen. Can you see? The child has a lot of androgen. Immediately you see this picture, your head will just be like, if I'm dealing with a lot of androgen in this child, then basically the enzyme that is deficient is either 21 or 11. Can you see the way you just, because in your head, this sketch, you just come to your head and be like, if I'm seeing a lot of androgen, so that axis is very active. So the enzyme deficient is either 21 or 11. Can you see? Now the abdominal image show bilateral adrenal hyperplasia. I actually jump a step. At least this one actually show you that there is hyperplasia of the adrenal gland. So immediately you see that, you now think, like, for me to now be seeing this elevated, to be seeing features of clitoromegaly, maybe I'm dealing with elevated androgen. All right, most likely the patient is deficient of 21 or 11. Then they say that this patient is most likely deficient for an enzyme normally responsible for which of the following conversion. So you have two enzymes at your, as your point now. Which one do you go for? The commonest enzyme that is deficient in them is 21 hydroxylase. Commonest is 21. You now remember that you say that the enzyme deficient in this region is 21 hydroxylase because it's the commonest. You now say, so for how will I know? And this is equation, and that guy was shouting, hey, don't cram this, don't cram that, don't cram this. Yes. You now say, he mentioned something, a molecule we should be looking for in the exam. If the 21 is deficient, then 11 DOC will not be formed. You now flip through all the options. Now say, I can see progesterone to 11 DOC. Yeah, that shows that this reaction will not really occur, because they say that this patient is most likely deficient for an enzyme normally responsible for which of the following reactions. Just remember 11 DOC and you pick, instead of you to sit down and be cramming jargons. And that is how the question. So all you need to do is you have the idea and you get into the exam, you will now be thinking. See, if you can't think, don't bother to say you are going to US, because now question and the like they will use to cripple someone, even in the real life, during all those stuffs. So you want to have an idea of how you pay attention to all these things. You just want to think freely, make the mistake. See, all those things you are running after. I want to be having, when I saw 40 questions in U1, I want to have 38, 39. They are bullshit. That's the reason why you are on the same spot. You want to be perfect. That's why you are no longer thinking. You are just cramming you word here and there. You are no longer thinking. Let us tell ourselves the truth. You are just, you've stopped thinking a long time ago. You are only cramming around. If they change any small thing, you are already thrown off guard, because you are not paying attention. This is not stuff. The exam is not stuff. This has nothing to do with stuff. You just want to think. If we sit you down for step 2 and we show you the way you think there, you will fall in love with the exam completely. You realize that those people that wrote first aid and even the USMLE, in fact, when you are going into the exam, you will be bouncing there. It's not about, am I going to get the question right or wrong? It's because you now know how to think. It's not until you are having 90-something percent, 80-something percent in you that you should be happy. You being able to think is already enough. You may not remember much a night to the exam. You can't even remember. Just like, I can't even remember anything in neuro. I can't even remember. But when you see a neural tube defect question, the the way you are going to do the analysis. Very simple. You just be like, this patient is having an Acromegaly until proven otherwise. That is what you are doing. And when you see a question that you don't know, you don't feel bad. Just think. All right, that is how you will be doing this. You realize no matter how complex the question may be, you are always going to be getting the answer because your analysis is now going to look a bit thorough. Then you come down to cortisol. With respect to cortisol, so you know that cortisol basically is released, it's actually produced from this adrenal zona fasciculata. All right, so these are the functions that you can actually affiliate with cortisol. All right, so let's see how we go about this. We need to sit down and actually cram. Not completely, but take note of the main point. Anytime you are revising, you don't want to forget. Number one, with respect to blood pressure, forget this at your own risk. You think they really care about the appetite? That is it. So they will leave all manner of questions. It's appetite they will be asking you. Even though it may be important, but they don't really go into those ones. But you see this blood pressure, expect question on it. Either in pharmacology or even in endo, blood pressure will be high. So cortisol can actually raise the level of, how does it do it? That's now the question you are expecting in the exam. Cortisol is going to upregulate alpha-1 receptor on the arteriole and now increase the sensitivity to non-epinephrine and epinephrine. You call that permissive action. We do it in pharmacology. How will I remember this? You have been doing it. You just don't know. You see, when someone in the hospital has low blood pressure, the blood pressure is going down. The next thing you see them shouting, hydrocort, 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 hydrocort. Nurse now, bring the hydrocort, collect it from the pharmacy. Everyone is shouting. They're like, So they just give the patient hydrocort. Bua. Now say, the BP is now rising small. The question is it the hydrocort that is raising the BP? No. This is what the hydrocort is doing, and that is what they will test. It's actually going to upregulate the expression of alpha-1 receptor on those arteriole. Endogenous non-epinephrine is already moving around in the system. So when the level is high, those non-epinephrine will now be binding to them. You now see a more pronounced effect of non-epinephrine. Permissive action. Can you see? So the presence of the cortisol, the steroid in the patient is actually making you to see the effect of this non-epinephrine and epinephrine in a more pronounced way. And this is what you are expecting in the exam. Just something related to this about the blood pressure. How come a patient on steroid is having hypertension? This is the answer. All right. Another one is at high concentration. Cortisol, that bastard, will also be romancing the mineralocorticoid receptor at high concentration. So if it's now romancing the mineralocorticoid receptor, what that means is that you will now be seeing the effect of aldosterone in the patient, despite the fact that the patient is not on aldosterone. It's not having elevated level of aldosterone. So what will aldosterone do? Reabsorb sodium, throw out potassium, throw out hydrogen ion. And that's what you see. That's number one. Number two, the effect you don't want to forget is actually with respect to the inflammatory and immune process in the exam. Inflammatory and the immune process in the exam. They will just tell you. So what it does is that it inhibits production of leukotriene, prostaglandin. So it can actually help with respect to pain. It's also going to inhibit WBC adhesion. Forget this at your own risk. This is what happens. They will test it. This is the first two. WBC, they have a way of actually being marginalized to the periphery, to the wall. Can you see the WBC? This is where they are, on this vessel wall. In the blood, most especially the neutrophil, in the blood, you realize that the level of neutrophil is not really that high. It's a bit down. When this patient now start taking the steroid, something will happen. The steroid that the patient is taking is going to demarginalize demarginate this neutrophil. All right, so they will move away from the wall and now come to the center. So it's now going to be giving you an impression that the patient is having elevated level of neutrophil. That is neutrophilia. That the USMLE will not test this, most likely is a lie. If I thought they are going to test something on inflammatory, this is the most tested in the exam. Very simple information. They will just tell you this patient is on steroid. What do you think is going to happen to the level of the neutrophil? There will be neutrophilia. Because this adhesion is going to be inhibited. So the level of neutrophil will now rise within the blood. What else? Look at the rest. You see, how come is neutrophil, they will ask? Because with respect to the rest, eosinopenia you have, lymphopenia you have. This is the one you have neutrophilia. That's the only reason why it's the one they will test. Which other one? Blockage of interleukin-2 production. Note it. So that's with respect to the inflammatory and immune response. Which other one? Is it just these two we are going to focus on? You can also look at the rest, increase insulin resistance, increase gluconeogenesis. So the possibility of the patient actually developing diabetes is quite high in the patient taking steroid. Can you see? Then reduce bone formation. So it's going to reduce osteoblast activity. But these first two I mentioned, forget them at your own risk. Now, come and see this. Exogenous glucocorticoid can actually cause reactivation of TB and candidiasis. How does it do that? It's going to block interleukin-2 production. So one thing about interleukin-2 is that interleukin-2 is actually one of these cytokines that actually help in the maintenance of granuloma. Can you see? In the maintenance of granuloma. You imagine that you are giving a drug that is blocking the interleukin-2. You just realize that the granuloma is going to break down. So a patient can actually have reactivation of TB, even become disseminated and the likes. Very easy concept. How do you regulate it? CRH coming from hypothalamus. We stimulate the pituitary to release ACTH. ACTH will now come to the adrenal and stimulate the release of cortisol. All right. So that's just by the way. Come down to the appetite regulation. With respect to the appetite, you have these guys called ghrelin, leptin, endocannabinoid. Ghrelin will stimulate. Ghrelin, look at ghrelin as grow. The patient is growing, is becoming big. Leptin, the patient is becoming thin. Leptin, the patient is becoming thin. Ghrelin, the patient is becoming big, is growing. So how will this hormone help the patient to grow? It's going to achieve that by stimulating hunger. Or start eating. We start eating. So it's going to stimulate hunger in the patient. So when the patient is actually very, very, very hungry, you can imagine the patient can also start eating and we start eating a lot in a way. So it can also help in the release of growth hormone. So that will also help in the patient to grow. So how is it helping in the release of growth hormone? Via the growth hormone secretagogue receptor. So that's just by the way, for you to have an idea. But the main thing is about the fact that it's going to stimulate hunger in the patient. Where is it produced from? Don't you want to ask? It's produced by the stomach. It's actually produced by the stomach. All right. So sleep deprivation, fasting, Prader-Willi. This is one of the things that we give out Prader-Willi in the exam, polyphagia. Prader-Willi syndrome, polyphagia. How come they eat a lot? They are hungry because they have high level of ghrelin in them. All right, ghrelin makes you grow hungry. So where is the hormone going to act? That's the next question. It's going to act on the lateral area of the hypothalamus. You think about it. I am talking here. You are looking here and there, sideways, laterally. All because you are hungry. When you are filled up, you focus. You look medially. You'll be looking at your screen because you are not hungry. So someone that is hungry is the most likely to be looking laterally. You know, in Yoruba language, you say, Mr. Lagbaja, say yes. In Yoruba language, permit me. Say, why are you looking here and there like someone that is hungry? All right. So you can actually look at it like that if you wish. So at least just for you to have an idea of how you will be looking at ghrelin, then leptin. Leptin is actually going to make the patient think. How does it work? So the patient will always be saying, I'm okay. Where is it produced from? Adipose tissue. So what this means is this. People that have high level of fat, they produce high level of leptin. So someone that is obese beside you is most likely going to have high level of leptin. So that person is not really supposed to be hungry. You know, say, Thai is a lie. This one will eat like anything, all because the person is big. So that is now the question USMLE will now ask you. How come people that are now obese are now eating a lot? If leptin is supposed to make them to be okay. So what happened is this. They can actually have mutation of leptin gene. They can also have resistance to leptin. After a while, because their body is always producing high level of leptin, all those receptors, they are no longer responding to the leptin again. Can you see? And it's now resistant. So when you check their blood, you will see high level of leptin. Can you see? But they are not, you can't see the effect because they are now resistant to those leptin. So they will now be behaving like they don't have leptin in their body. So they will now be eating like mad. That is the reason why you see people that are obese, they still eat a lot. They are already having leptin effect abnormality. Only because they have a lot of fat, they start producing leptin. They can relate it to leptin gene. Just don't forget the story around it. In the exam, they can give you all manner of questions. You just need to look at it and think and be like, this is what I feel is happening here, basically. So endocannabinoid acts at the cannabinoid receptor in the hypothalamus. All right. And the nucleus accumbens in a way. So it's also going to help in increasing the appetite, people that take it. You come down to what we call the signaling pathway of endocrine hormone. You say, shit. We need to cram these molecules. Not necessarily. The one you can pick. The one you can't pick, let it slide. Just let it go. Don't kill yourself. So let's just pick 1 or 2 points here and forget about the rest. CAMP is a second messenger. So, you see, these are the hormones that we use this CAMP as their second messenger. What will the CAMP do is just going to activate or stimulate the protein kinase A. All right. So they will just mention some of these hormones. Since I actually started this class, I've mentioned a particular hormone, PTH, where I mentioned that you will see elevated level of urine CAMP. At least you've picked one. Add ACTH to it. Add glucagon to it. At least you've tried. You can leave the rest. If they ask you, and means the one you've noted, fine. If they do not ask you, please, that is okay. Don't kill yourself. They may not even test you on it at all. So why you hard on yourself? So that's that. ACTH, PTH, glucagon. If at all you can still add more to you can remember this mnemonic. Fine. If you can remember, it's hard for you. Just at least remember 1 or 2 and say to yourself that as the Lord liveth, the one you are going to ask me, will fall within the ones I know. Don't drop God. Stuff can fail you, but He will not fail you. He won't. He doesn't. He won't fail you. You are underestimating Him. Just ask Him for help. I don't want to read so much. Please help me. You just realize that you go into the exam, come out, and see everything I read came out, and I was just picking answer. And some people will read a lot, solve all manner of questions, and come out and be turning their head upside down and be shouting, God, now have mercy on me. How come you didn't ask for that mercy before you go? So when you come here, what I'm trying to say is that if at all you don't even, it's looking jumper, just say, God, just a simple prayer. Which one do I focus on? Help me. You just realize that your mind will just go to a particular area and you'll just be like, okay, let me pick this. CGMP, okay, BMP, AMP. And you get into the exam, they will just ask you, just pick it. It now look like you know it. So that's that. So for the CGMP, you relate that to brain natriuretic peptide, atrial natriuretic peptide, and ADH. All right. So look at this IP3 too. You can relate it to these hormones. So GnRH, histamine, and the likes, ADH, oxytocin. Intracellular receptors, these hormones, their receptor is actually located within the cell. These are them: vitamin D, progesterone, estrogen, testosterone. So at least some people keep their pets inside the house. So pet cat in TV, maybe that may help. You see, receptor tyrosine kinase, you now say you forget insulin. That is not acceptable. And you remember us saying insulin builds. So you can relate it to growth factor. Insulin-like growth factor 1, fibroblast growth factor, platelet-derived growth factor, and the like. So you can just relate them to that. What of non-receptor tyrosine kinase? They are related to those cells, red blood cells, erythropoietin, thrombopoietin, prolactin. So they are just related to those stuff. Granulocyte ghrelin stimulating factor and the likes. So you can just pick the one you can pick there and move on. So you come down to what we call the signaling pathway of steroid hormone. Is there any concept here you want to remember? You see, God is so wonderful. God, there is a particular binding globulin you must never forget in the exam. You call it sex hormone binding globulin. God is so wonderful. Let me tell you something about it. It's just related to testosterone. So, in female, they have testosterone. So, let me even relate it like this. This is a male. This is the female. Female have testosterone. Male also, they also have testosterone. But there is what we call sex hormone binding globulin. So sex hormone binding globulin. You remember there is a particular binding globulin we mentioned not too long that is related to the thyroid. It's also tyrosine binding globulin. You get. So all those ones, they are actually influenced by estrogen. What does that mean? In the exam, the concept does not change. Anytime estrogen level is high, binding globulin level will rise. So this patient that is a female, young, that is having high level of estrogen, the sex hormone binding globulin will be high. It doesn't still change from the way you were looking at the one for thyroid. It's the same concept. The level will be high. So what will this one now do? All this testosterone in them, they will start binding them. When they bind to them, they will reduce the level of free testosterone roaming about. Therefore, the female will look more like a female. It's in a situation where this sex hormone binding globulin is not really produced in that female. Maybe the patient has a liver problem and the likes. You just realize that the sex hormone binding globulin is low. Most of this testosterone in that female will not be bound. They will still be appearing free. They will be moving around, and that female is now going to be looking more like a male. They start growing bare, that they start competing with their partners in the house. They start having all manner of stuff. Is that the only situation where I will see a female having bare, having mustache, having all manner of stuff? No. But the situation, the way they are going to portray it is going to give it out. You will know that, okay, this patient is actually having a low level of sex hormone binding globulin. So it's going to give out itself. Please help us to mute your mics. It's going to give it out. Now, the same concept is applicable to male. I don't expect male to have high level of sex hormone binding globulin. That male will be looking more like female. Because once the level of testosterone drop, the male will be looking more like, what's going on? So high level of sex hormone binding globulin in male is abnormal. Is abnormal. So you will now be seeing the magnified effect of estrogen in that male. You start seeing something like gynecomastia. You start seeing something like reduced libido. You start seeing all manner of stuff. All because sex hormone binding globulin is high in that male. So all you need to do in the question is to sit down, look at that question again, and be like, what are you trying to test me on? Think and pick. You come down to syndrome of inappropriate antidiuretic hormone secretion. Well, the name has already spoken for itself. This is a syndrome where ADH is secreted inappropriately. The level is so high. You now ask yourself a question. If the level of ADH is high, what is ADH supposed to do? You say, ADH is supposed to come to the kidney and actually cause reabsorption of water into the blood. So what does that mean? In a situation where ADH level is no longer responding to osmolality, so the level of water reabsorption is going to be so high that the blood is going to be overly dilute. So you just realize that the sodium level in that question is just dropping. Just see, the patient is just having hyponatremia, SIADH, hyponatremia. The level of, so because this is a dilutional stuff, you just see the level, the sodium is just going to be low. You realize that. Then when you check the urine, you realize that urine is going to appear concentrated because most of the water in the urine has been reabsorbed. So because they have been reabsorbed, the urine osmolality will be high. The serum osmolality will be low. And that's the kind of picture you want to rehearse and take into the exam. It's very simple picture that they can be giving me something about sodium, they can be giving me something about urine osmolality, serum osmolality, and the likes. All right. There is a way the body will respond to the water retention you are seeing in the blood. It's more or less like an escape mechanism. It's more or less like an escape mechanism. All right. The body is going to reduce. So the body is going to reduce. Sorry. So the way the body is going to respond to this water retention you are seeing here, you also see this aldosterone level as actually also being low because you're now having a lot of water being retained in the body. So the body will reduce the aldosterone. Is now going to raise the level of ANP, BNP. What will ANP do? What will BNP do? They will throw out sodium. You think they call them natriuretic peptide for joke? They actually give them those names for a reason. So they will throw out sodium. And as they are throwing out sodium in the urine, water will follow. Can you see? So in the course of doing that, you realize that the extracellular fluid volume is now going to be coming back or down towards becoming normal. All right. This escape mechanism you talk about is throwing out sodium in this patient. We say yes. That means the patient is going to be hyponatremic, and that is it. The sodium in this patient will be low. and the patient is most likely going to be eupholemic. So you may not really see the evidence of dehydration in the patient, but the sodium will be low. Now, how will the patient now present? The commonest way the patient is going to present is with confusion. They just tell you that this patient actually had road traffic accident and had head injury. This was also time. And since that time, after a while, the patient has been becoming confused. You go, you check, you do the brain CT and all manner of stuff. So you can't really see anything. All right. You may actually be dealing with SIADH because when there is head trauma, you see SIADH, excessive release of ADH will occur and it will be causing this. So the patient will eventually become hyponatremic. So just be confused. You just look out for it. That's also the same reason why someone that is having meningitis, we are very careful giving the patient the normal fluid because they also release ADH in a way. So you don't want to give them excessive fluid because you will be worsening it. The hyponatremia in them may be worsened when you are giving them a lot of fluid. You want to be very careful. You can also be dealing with ectopic ADH being released from the lung, small cell lung cancer. You can also be dealing with exogenous hormone like vasopressin. The patient may just be taking it. Or you may be dealing with drugs like SSRI, carbamazepine, cyclophosphamide. They will just mention them. Just realize that the patient has hyponatremia, and you will see any of these guys there. You just be like, it's just this hyponatremia I'm seeing, the confusion I'm seeing in this patient is related to medication. It's related to small cell lung cancer. It's related to head trauma. You will just see it there. So what we give it out is the confusion most of the time. How do you want to treat? The treatment that if you forget it, no one will forgive you is fluid restriction. This is it for step 1, for step 2, for step 3. And if at all you check that question, you realize that the sodium is less than 120. Your answer becomes hypertonic saline. Now tell me, what is the stuff in this thing? All you just need to do is, and you don't need to get all the question, at least you have some point you are using to look at the question. Okay, you see, fluid restriction. So just remember, rehearse it, ask your friend. So when you get into the exam, like, Baja, what will you remember? No, we try to the treatment too. Don't forget fluid restriction is the answer. Unless the sodium they are giving there is less than 120. That's when you go for hypertonic saline. You come down to the primary polydipsia and diabetic insipidus. So I just gave it this color and I gave this to this color. First of all, in the exam, what will you see? You just realize that this patient is passing a lot of urine. The patient is passing a lot of urine. And you will go and check the question for the glucose. They say the glucose is normal. So definitely this is not diabetes mellitus. It's another thing entirely. Am I now having primary polydipsia where the patient is just taking a lot of water? Or I am having diabetes insipidus where the patient, the kidneys are not responding to either the ADH is low or new or they are not responding. At least one of them is out there. All right. So you don't know which of them are you dealing with. In the exam, the first thing you do is what you call water restriction. That's your answer. You want to separate this primary polydipsia from diabetes insipidus. You just say, first of all, this patient should not be taking water. So when you are reading the question, that's the same lens you are using to read it. Water restriction. If after doing water restriction, you realize that the patient now start becoming better, then your diagnosis is primary polydipsia. You realize that the urine is now looking concentrated, then that shows that you are dealing with primary polydipsia. Again, this patient is just passing a lot of urine. The urine is, when you check the urine osmolality, it will be very low. It's not concentrating. So the question is this patient consuming a lot of water or the patient is having problem with ADH, either response to ADH or quantity of ADH in the system. You don't know. So you will now check the question, have you done water restriction? If the question says they did water restriction, and after restricting the patient in taking water for some hours, they realize that the urine start becoming concentrated, then your diagnosis is primary polydipsia. It means the patient was just consuming a lot of water. But if the question says the patient should not drink water and they are still not seeing any significant change in the concentration in the urine osmolality, then you are dealing with diabetes insipidus. So what is difficult there? Just look, think, and pick. You just check, what am I dealing with here? Is the urine osmolality high? Is it low? Oh, it's very low, and the urine volume is very, very high. Am I dealing with primary polydipsia or diabetes insipidus? Quickly trace the question. Have you done restriction, water restriction? They say we did it, and we realized that after restricting the patient for this for water for this also number of hours, the concentration of urine starts rising. Then your answer is primary polydipsia. Oh, we did not see any significant change in it. Your diagnosis is diabetes insipidus. So you now want to check, are you dealing with central or nephrogenic? What is central? Central means that the patient is not actually releasing ADH. The ADH is low in the patient. What is nephrogenic? The nephrogenic means that ADH is actually okay, may even be high, but the nephrons, they are not responding to the ADH, and that's all. Can you see? And that's all. All right. So that's just by the way. So you just check the question. There is now a test they are going to do. You call it desmopressin administration. So when you give the patient ADH, which is more or less like ADH. So when you give the patient, and the question says that the patient respond, the urine is now becoming concentrated after giving the patient ADH, desmopressin. So it means the patient does not have ADH ab initio. So your answer becomes central DI. But if the question says they give the patient and they are still not seeing any effect, then most likely you are dealing with nephrogenic. Kidney is not responding. It shows that even ab initio, the patient has enough level of ADH. Those nephrons are not just responding. So can you see the way you separate them? And that's just the main thing. So if the diagnosis is central, all you need to give to the patient is desmopressin. If your diagnosis is nephrogenic, so you can actually manage with these drugs. Hydrochlorothiazide, amylora, indomethacin, low solute diet. So if your diagnosis is primary polydipsia, water restriction. So I put something here, significance of water deprivation test in the exam. They just want to use it to separate primary polydipsia from DI. Then how do you differentiate ADH between ADH disorder and primary polydipsia? So that is water deprivation test. Then you come down to what we call the hypopituitarism. Hypopituitarism. All right. So when you hear the word hypopituitarism, all the hormones that are supposed to come from the anterior pituitary, they are down, they are low. That's hypopituitarism. So you use the word hypopituitarism. If the hormones you are supposed to get from both anterior and posterior are low, that is when you use the word hypopituitarism. It's cut across the posterior pituitary too. That's what that means. So now they will just give you when you check the question, you will see that those hormones are low. So they will now be expecting you to pick that. Are you dealing with Sheehan syndrome, empty cellar syndrome, pituitary hypoplasia, or which one are you dealing with? This is how the question will go. So you just need to look at that question. There will definitely be a clincher there that will tell you that your answer is Sheehan. So for the Sheehan, what you will see is that the patient at one point in time had postpartum hemorrhage, and that's all. Delivered or had abortion, lost a lot of blood, that they even needed to be giving the patient all manner of pint of blood. Just the patient had a lot of blood. Lost a lot of blood. You say most likely you are dealing with Sheehan syndrome. Just pick the answer. So this is what we give it up, postpartum hemorrhage. All right. With respect to the empty cellar syndrome, This is most likely going to be associated with idiopathic intracranial hypertension. Idiopathic intracranial hypertension. All right, so please never forget this. So you can easily what do you call it? You can call this one, you give it a well-decorated name, pseudotumor cerebri. So you just see the level of pressure, intracranial pressure is actually quite high. The next thing is, the patient has a space occupying lesion. The patient has you now go and do MRI, you won't see anything there. The pressure is just high. And they have some attributes, some factors that usually contribute to it. So, being a female, being that is obese, that is or also taking maybe tetracycline or danazol and all manner of stuff, they can actually make the patient to develop this idiopathic intracranial hypertension. So you imagine you being a big person and you are sitting on pituitary. How do you think the pituitary, what do you think the pituitary will become after a while? We shrink. That is, the pituitary is supposed to sit in what we call the sella turcica. So that high level of pressure on it, after a while, you see the atrophy of the pituitary. Can you get that? That atrophy of pituitary will now make the sella turcica to look empty. It doesn't mean it's empty. It's just shrunken. The pituitary is just shrunken in that, so you call that empty sella syndrome. So what is that thing that will give it out? Must have been an evidence of intracranial hypertension in the patient. What of pituitary hypoplasia? You see you see hypopituitarism. Can you see hypopituitarism? And you see something that is related to intracranial hemorrhage. So sudden hemorrhage of pituitary gland in the presence of an existing pituitary adenoma. So that is pituitary hypoplasia. So this picture of sudden hemorrhage will be there. Sudden headache, severe headache, associated with this. And the patient also had hypopituitarism. They will just list those hormones. You just their level are low. You just say this is pituitary hypoplasia. So what you will do is to pick a sheet of paper and now write in capital letter hypopituitarism. All the hormones from the anterior pituitary are low. If I check, that's how you'll be writing it though. If I check the question and I see evidence of severe postpartum hemorrhage, I will go for SIADH. If I check the question and I see evidence of intracranial hypertension, I will go for empty sella syndrome. If I check the question and I see evidence of sudden hemorrhage into the cranium, I will be going for something like pituitary hypoplasia. And that's just how you look at it in a very simple way. And you just go and solve some questions on that. You realize that most of those questions will just be getting them because now you know how to look at hypopituitarism in the exam. Brain injury is also there, radiation. So how do you treat it? All those hormones that are low, that the question is saying are low, replace them and the patient will be fine. Acromegaly. Acromegaly. With respect to acromegaly, we just have excess growth hormone. Where? In the adult. All right. Excess growth hormone in the adult. Okay. That's very fine. How will I even know that I'm dealing with excess growth hormone in this patient? I put something here. You just see something that related to excessive soft tissue growth problem in the patient. How will you have put it if you were to be the one setting questions? So they can tell you the patient tongue is becoming bigger. The patient's frontal bone is actually shooting out. So the voice is becoming deeper. The patient is now having body odor. So the patient is complaining of joint pain. Can you see? Joint pain. All right. The patient is also having a newly diagnosed diabetes mellitus. The patient's blood pressure is rising. You will just start writing all manner of stuff. Then when they check the heart, they did echo. They realized that the patient is also having left ventricular hypertrophy. You just realize how come everything is increasing in size in this patient. Most likely I'm having excessive growth hormone being released. Growth of tissue. Growth of tissue. Festus, why did you now highlight hypertrophic arthropathy? One of the most tested in the exam, together with heart failure with preserved ejection fraction. Most tested in the exam. So you can't go. You see all these deep voice, diaphoresis. No one will test you on it. coarse facial. No one will tell. You see this hypertrophic arthropathy in the exam. Expect it. Very easy concept. Just expect it and be like, I'm expecting them to actually test me on something like this. All right. What of how do you make the diagnosis in the exam? That same molecule you were shouting, don't forget that you were like, Festus, shout little now. Is the same one. Elevated level of serum IGF-1 somatomedin, C, insulin growth factor 1. All right. You expect this. You expect growth hormone to be suppressed, you remember, by glucose. When the patient is actually taking glucose, you expect it to be suppressed. So you will realize that the question will say that there is failure to suppress serum growth hormone following oral glucose tolerance test. You remember, because high level of what is actually supposed to suppress it normally is actually hyperglycemia. So when you give the patient, you load the patient with glucose, you expect it to be suppressed. But it's not just suppressed, just this patient is having excessive release of it. How are you going to treat? All right. So when you see that, before I go, you can also see them mention something like MRI, because you are most likely going to see the pituitary adenoma there. Okay. How are you going to treat? The summary of the treatment for now is surgical resection. So if I thought they asked it in the exam, this is what you are looking for: surgical resection, surgical resection, surgical resection. If I thought this does not help, that is when you start looking for drug. So this is your answer, because they will list both the surgical resection, option A, option B. They will now give you the Electrolyte. They will just put it there. In fact, another option you should expect is this drug, pegfisomat. They will just put it there. You now be like, which one will I pick now? Which one will I pick? Your answer is going to be the resection. That's your answer. The first aid is very clear. So sit down and now master this point about the acromegaly. Now go and write the exam and say that they brought one question and you don't know how to think about it. Then you didn't use first aid. You come down to the hypothyroidism. Hyperthyroidism. So how will you even first of all know that this is hypothyroidism? Check the level of the TSH. In hypothyroidism, you know definitely the TSH is going to be very high. That's hypothyroidism. So that's that. Can you see? The level of TSH is going to be high. In hyperthyroidism, the TSH level is going to be very low. What of thyroid cancer? Most likely the TSH is going to be normal. Can you see the way you are thinking? Just from TSH alone, you look at the question, you are already like, okay, with what I'm saying here, this is most likely related to... This is most likely related to hypothyroidism from the TSH level in the exam. Okay. All right. So that's just by the way. Now, how do you want to look at the way the patient with hypothyroidism, how the patient will present? You just want to note the key point. That once you see it in the question, you just be like, that's the answer. So what's the first one? Hyponatremia. You see, cold intolerance is something that is common. So once you see them mention cold intolerance, you start thinking towards something like hypothyroidism. Heat intolerance, hyperthyroidism. This is not what you don't know. It's what you are most likely you've been applying in the practice. All right. So the next point here is you don't want to forget hyponatremia for the hypothyroidism. Then they gain weight. Can you see? Still, they now give you a question. They say the patient has cold intolerance and weight gain, then hypothyroidism and no matter of. So once you even see cold intolerance, you will start saying that hypothyroidism. So with respect to the skin, once you see something like dry and cool skin, you already know you are dealing with hypothyroidism. So you don't need to really be cramming what is not lost. You just need 1 or 2 points that will give out the hypothyroidism in the exam. All right, so that's just by the way. Then the next important point, you can look at the GI. They can have constipation. So they can also have puffy face, generalized non-pitting edema. You call that mixed edema, which is due to increase in GAG, glycosaminoglycan, in their interstitial. You just want to remember GAG anyway. Once you see it, you will know. What about the musculoskeletal? They can have what we call hypothyroid myopathy. So they will just be having proximal muscle weakness. And when you check it, you will see that the creatine kinase is actually high. So do you also have something like thyrotoxic myopathy? Yes, we have it in hyperthyroidism too. But in this one, the creatine kinase will be normal. Can you see the point you are noting for the exam? You just note them so that when you read the question, you'll be like, okay, this makes sense. Then look at the hyperthyroidism again. So we've already mentioned some of these guys. You can see. So this, what do we call his name? They can have weight loss, heat intolerance, weight loss. The weight loss is coming from increased synthesis of sodium potassium ATPase, which is now going to raise their basal metabolic rate. Very easy. That's that. So the next important point is when you read question and you see what we call ophthalmopathy. So ophthalmopathy. So you are seeing something like periorbital edema, esophthalmos. Just go and pick grave disease. That's the answer. Don't say it could also be another thing. It could not be another thing. Just pick grave disease and go. Just by the picture that you see alone, you just see esophthalmos. You just say, this is grave now. This is grave. So, and that's that. All right. You can also see some other stuff like lead lag, lead retraction, and the likes. So, but these are the main points you don't want to forget in the exam so that you don't want to end up putting unnecessary jargons at the back of your mind. The next important point I may want to say is about the reflexes. So, with respect to the hypothyroidism, you see delayed or slow reflexes. You can see reduced reflexes. With respect to the hyperthyroidism, you see increased reflexes. You know what can confuse you in the exam is this word brisk. If you don't take your time to note that the word brisk means hyperreflexia, you may not know, because they will not say hyperreflex, just say the reflexes are brisk. You now say reflexes are brisk. You need to look at the question very well so that you don't go and pick what you are not. So this is hyperreflexia. Then there is something you see in their cardiovascular examination for the hypothyroidism, bradycardia, for the hypertachycardia. Then with respect to their steroid, to their lipid profile, so you see hypercholesterolemia in hypothyroidism. Where is this coming from? This question should expect it in the exam. Where is this hypercholesterolemia? That's why I needed to write it out big, so that at least when you see, you know. Reduce LDL receptor expression. Reduce LDL receptor expression. So they will just give you those hypothyroidism patient and the likes, and just tell you that the cholesterol level is high. Which of the following is most likely responsible for the cholesterol that is very high, or the laboratory finding? So your answer will now be reduced LDL receptor expression. What of in hyperthyroidism? You see all those LDL, HDL, total cholesterol, all of them are going to be low. So this is the one you see hypercholesterolemia. Then you come down to this hypothyroidism now. Please and please, hypothyroidism can occur on its own. It can also follow it can also follow all this thyroiditis. And I already told you how you differentiate. In thyroiditis, you can see hypothyroidism, you can see hyperthyroidism. So this is how you look at it for thyroiditis. This is the cell. It lies in a way, the content released, and the content T3, T4, thyroglobulin. You just ask yourself, immediately they are released, the patient will be in what we call hyperthyroidic state. So the patient will be behaving like someone that is having hyperthyroidism. After a while, the level will drop to normal. You call it euthyroidic state. After a while, the level will drop below normal. You call it hypothyroidic state. And that is the reason why you can see the patient with thyroiditis developing hypothyroidism. So don't forget what I say is going to give out thyroiditis in the question. you realize that it's going to really help. So another thing again with hypothyroidism is TSH. The TSH they will give you in the exam will be quite what do you call it, high, very high. So that's when you know that you are dealing with hypothyroidism. So what are the examples you want to take into the exam? Number 1, Hashimoto thyroiditis. Hashimoto thyroiditis. Hashimoto thyroiditis. So when you get into exam, look at those thyroiditis question and divide it into, is it painful or painless? So what is painful, what is painless? First of all, you didn't mention it. Yes, it's actually their neck mass. They can have a neck mass. And that neck mass, where is it coming from? From the TSH, that is high, thyroid stimulating hormone. It will be stimulating their thyroid, stimulating it will now be big. So they have a neck mass. You will now check that question. Are you saying this neck mass is painful or painless? So the question will mention it. Once you see that a patient is having a neck mass that is painful, you now check the TSH. The TSH is high. Your answer is going to be subacute granulomatous thyroiditis. Another name for it is decurving. We call it decurving. It's the one that is painful. So this is the only one you pick. And you will see some other clinchers there. Viral infection, preceding viral infection, elevated ESR will be in the question. You just say this is decurving. Even if you don't remember the full name, you see it in the exam. They mention, you see it's tender. You just remember it's actually that decurving. Or you call it subacute granulomatous thyroiditis. Just by seeing pain. If the question says that mass is painless, you can be dealing with Hashimoto or Radel. Hashimoto thyroiditis, another name for it is chronic autoimmune. So this is autoimmune. Can you see? Autoimmune. And it is the most common form or the most common cause of hypothyroidism. Hashimoto. You can't go and say I left Hashimoto at home. Hashimoto. Most common. So the question is going to revolve around some other autoimmune in that question. What are they? They may say the patient also has type 1 DM. They may say the patient also has Addison disease. They may even be saying that the patient has SLE. Just know you are dealing with Hashimoto. That autoimmune components may be the one that will give it out. You just remember, amidst all of them, it is the one that you don't want to forget that usually is autoimmune related. The Radel may also look like related to auto, but it's not pronounced like this. So this is the main autoimmune, the one that's related to autoimmune. All right, what are the other things they will put in question for us? If it's autoimmune related, then when you try to do biopsy for it, and you send that biopsy, the tissue you send it for histology, you are going to see what we call the O2 cells. O2 cells. You will see O2 cells. All right. Never forget that. O2 cell. Then another thing again, you can also see in them is what we call the lymphoma, or you say lymphoid aggregate. So you can see lymphoma. So that lymphoma is usually the diffuse large B-cell lymphoma. Anytime we have the opportunity of sitting you down and showing you around the hematology, we'll simplify all these lymphoma for you. You don't need to cram them. So you just see lymphoma. Now, let's put them together. We just say Hashimoto thyroiditis related to autoimmune. So I may see, that's how you'll be telling yourself, so I may see any other autoimmune condition in the exam, in that question. Okay, and it's not tender. Okay, not tender, O2 cell. They will ask you about the O2 cell in the exam. Histology will show which of the following. Your answer is just O2 cell. So we call it NHL, non-Hodgkin lymphoma. NHL, non-Hodgkin lymphoma. What is that non-Hodgkin lymphoma type that you are most likely going to see in them? Diffuse large B-cell lymphoma. What is the N? Not tender. What is H? O2 cell. What is L? Lymphoma aggregate, which is diffuse large B-cell. NHL. You can look at it like that. All right. So there is a variant of it of Hashimoto thyroiditis, you call that postpartum thyroiditis. So this one usually arises in less than 1 year after delivery. So the question for this postpartum thyroiditis will be related to delivery. And that's all about the Hashimoto. And we've already done the subacute. What about the radial? The radial is also non-tender. It's also non-tender. The thing about it, when you see someone is a rebel, is it rebel they call it? Someone is a rebel. Maybe I may not be too correct in my interpretation of someone I say is a rebel. It's more or less like someone that is maybe very stubborn, not really belonging to the group, or whichever way you want to look at it. So you can look at it like that. So it is the one that is invasive. It's always going elsewhere, infiltrating into the surrounding structure. So that is the rebel. So you can see it actually. You are going to see it has a lot of fibrous tissue with it. You call it invasive. That's another name you call it, invasive fibrous thyroiditis. So those fibrous tissue will now be invading the surrounding structure. They can pick the esophagus, they can pick the trachea, they can pick. So that's a rebel. Do you get me? So when you can look at it when you say someone is a rebel. So how the person can be behaving. The same thing you can bring it here if you wish. So if you are now having fibrosis around the surrounding structures like trachea, esophagus, and the like, you realize that the patient will start having difficulty with breathing, difficulty swallowing, and all manner of stuff. So you say this is a rebel thyroiditis. So in all of them, TSH will be high. I look at the question and I'm like, okay, this is thyroiditis. The question does not mention anything. The question mentions something. They can mention something about the thyroid globulin. You'll be okay, this is thyroiditis. You now check. Can I see any features of autoimmune in the question? They say no, it's not there. So check again. Can I see, is it painful? Is it painless? They say it's actually painful. Your answer is going to be subacute. The core pain, the core vein. It's painless. You say it's either I'm dealing with Hashimoto or radial. You now check. Can I see autoimmune? I can see autoimmune. That is most likely radial. Can I see autoimmune? I can see autoimmune. Most likely I'm dealing with Hashimoto. It's just in 1 or 2 sentences. And you just take that into the exam and you are okay. You just take that and you just think freely. So you won't remember most of the points, but at least the main point, you still pick them and you use them to solve questions. What about the congenital hypothyroidism? Definitely. The most tested question here, whether step 1 new or step 2 new or step 3 new, is thyroid dysgenesis. What is causing it? Thyroid dysgenesis. Can you see it? Thyroid dysgenesis. So if you can pick it from step 1, it's already going to give you headacheless analysis in the exam. So just a thyroid dysgenesis. That's the most tested. What is causing a congenital hypothyroidism? All right. How will the patient behave? How will the patient present? So you just see them give you a picture of a patient with pot belly. So with pot belly. So you just give you a picture of a patient with pot belly. So they can also give you, in that picture, you may see that the umbilicus is actually protruding, more or less like the patient is having umbilical hernia. Can you see the way you are looking at it? So when you see a baby that they are just delivered with, the tummy is big, so there is hernia, so you'll be like, oh, I'm not dealing with congenital hypothyroidism. If not that, it could also be Down syndrome. So you just look at it, check that question again. Am I having those 2 options there? If you have the 2 of them, check that question again. There must be something that will throw 2 of them apart. All right. So please never and never forget that. So you see something like pot belly. Never forget this umbilical protrusion. Is one of the things that will give it out there. So can you see? Thyroid dysgenesis. Never forget that too. That's the main point. Like, I needed to put it in red, arrow it, so that you will not forget it as you are going into the exam. So these are the other causes. We've talked about the Wolf-Chaikoff effect and the likes. So please never forget them. And this is the hyperthyroidism. So these are the causes. Just 3 main points you don't want to forget here. The causes. So one of them is, 4. One of them is grave. At least for now, for the USMLE you are about to write. Grave disease. How will I identify that this is grave disease? How will I know this has something to do with toxic multinodular goiter? Can you see? So that's just by the way. How will I know that what I'm dealing with is actually thyroid adenoma? Something like that. So that's how you look at it. Then how will I know I'm dealing with thyroiditis? So because in thyroiditis, they can also have hyperthyroidism. So when you check the question, never forget to look for thyroglobulin in it. So if they give you the thyroglobulin, they say that someone is having hyperthyroidism and thyroglobulin is high, then your answer is going to be thyroiditis. So it has nothing to do with these guys. But if they give you the hyperthyroidism in question and the thyroglobulin is not, you don't see it, it's not high, then most likely you are dealing with any of these guys. So for the grave disease, how will I identify it? What we usually use to identify it in the question is this high. You see the way this patient is looking at, most likely to be a woman anyway. So you see the way this woman is looking at you. So this is what you call esophthalmos. Once you see it, your answer is grave disease straight up. Don't go and be negotiating it. We know you like to negotiate. You like to bargain. Don't go and be bargaining here. Just pick grave disease and move out. Leave the rest for them to determine. So you just pick grave disease and that's all. All right. So what is actually, the next question is, what is stimulating the thyroid hormone in them that is making thyroid gland in them that is making them to produce the thyroid hormone? Now say thyroid stimulating immunoglobulin. This is what is stimulating it. Not really the TSH. It's actually the TSI. Can you see? TSI. So it's the one stimulating the TSH receptor, not the TSH. So TSI is the one stimulating the TSH receptor. Where will those receptors be? On the thyroid. So they will have hyperthyroidism on the derma fibroblasts. You see them having pretibial myxedema. On the orbital fibroblasts, you see them having what you call the esophthalmos grave orbitopathy, at least something like that. And that's all. So these TSI, they are the ones stimulating the TSH receptor in all those places, in the eye, on the tibia, then with respect to the thyroid gland. Can you see? Very easy and straightforward. Really no big deal. What will I see in question that we give it out? You can see esophthalmos. So is there any other thing that is maybe associated with grave disease? It's also autoimmune. So it can be associated with any other autoimmune condition too. All right. Histology wisely, how will they describe the cells? You see this description in the exam. Tall, crowded follicular epithelial cells. Can you see? They will be described. All right. So that's just by the way. I put esophthalmos here because once you see it, just be like it's grave. And you see them testing this TSI. The next thing is, what is the treatment? But this is the treatment. It's not just you knowing that the way you collect this. No. Your answer is about the arrangement. The first drug they need to give to the patient is what? Beta blocker. That's your answer. They will say beta blocker, antithyroid drug. They will list all of them there. Your answer is beta blocker. It's all about arrangement. So when you start preparing for step 2, and you have the opportunity of using the concept, so you will be able to see how we unravel the mystery about the way you go about the best next step. So you see, first aid has already finished the work for you. You just don't know. What you are looking for in Sokoto is actually in the pocket of your trouser, but you don't know. You are carried away by the noise in the public. Sit down. You don't need many material. One material is okay. Sit down with that one. At least know the one very well and go. And let them say, okay, that one is not enough first. Sit down. Use that one material. It is there. It's all about arrangement. You are taking into that exam. The question will tell you that the patient has taken beta blocker. What's the best next step? You go to the antithyroid. So if the patient has not taken any drug, and they just say what's the best next step in step 2. So it's all about it's just about this arrangement. Beta blocker. Just look at the option and pick beta blocker. That's the answer. Even though antithyroid is there, you know, the confusion someone may have is that they collect antithyroid too now. They also collect beta blocker. Which one will I now pick now? You now forget that it's all about arrangement. So your answer is going to be beta blocker. All right. So that's just by the way about the grave. That's just the summary you don't want to forget. For the toxic multinodular, all you see is that you have the thyroid gland like this, and you have the thyroid gland like this. So I now have multiple nodules around that are working independent of TSH. They are just pushing T3, T4 into the system. You have Who is pushing T3, T4? They say there are some nodules there. Who is telling you to push them? Is it TSH? They say it's not TSH. TSH is shouting, I don't know anything about it. In fact, if you check my level, go self, I'm normal. Really? What is going on? T3, T4, what? So this, you call this, when you now do the imaging, you will see multiple nodules that are actually active like this. That's how you come across the name multinodular. Do you get? So there are many. If it's just only one nodule you won't call it multinodular. Do you get it? You won't call that one multinodular. So that is going to be something like this thyroid adenoma or something related to that. All right, so that's just by the way with respect to this. Can you see? So in the exam, they will just ask you, where is the problem coming from? That's the answer. TSH receptor mutation. The TSH is having a mutation that is making it to behave like TSH is binding to it. All right, what of thyroid storm in the exam? How will I know this is thyroid storm? How will I know this is thyroid storm? So you just see someone that is having hyperthyroidism and that patient is having delirium. That's all you need. You don't need any other information. We know you like too much stuff, but that is more than enough. They say this patient has high level of this T3, T4, blah, blah, blah. And you check the question, you are seeing the patient is confused, is aggressive, is this, is that. And that's what is this. Most likely you are dealing with thyroid storm. You now check back that question. What did you do to this patient that is making this patient to be experiencing thyroid storm? You now say, the patient recently had a surgery. Oh, the patient had infection. Oh, the patient had a trauma. And I'll say that is the cause. So the cause is going to be in that question. But the question is most likely just going to be about you diagnosing it as thyroid storm. All you need is you can establish that the patient has hyperthyroidism. So, and you can see that the patient is actually having something that looks like delirium. So the next best step is just about you treating the patient. How do you want to treat the patient? I gave it a name on a bag. So BAIG. So bag. So beta blocker too. So you just pick beta blocker and you can see the patient can also get antithyroid. You can give the patient antithyroid. So you can see it's also about the arrangement. So in the exam for step 2, this is your most tested, this is your most likely question. Just beta blocker. Just say what's the best next? Just beta blocker. So iodine is also another one that is here. Then the last one is glucocorticoid. So you can say because the patient is having thyroid storm, you now say I want to give the patient glucocorticoid. Even though it may sound like you are correct, but you are actually going to be wrong. The answer is beta blocker. So it's all about arrangement too. So if you look at it, just arrange it for us. We've already given it to you. Arrange it. Just go into the exam arranging. Just go in and go and be arranging them. So just say what's the best next step. What did you say you've given? Say we've given beta blocker. Then go proceed to the antithyroid. So that's the next one. That's the next one. What did you say you've given? We've given antithyroid. Okay, then you can produce the potassium iodine. So it's all about arrangement. If I thought this actually tested in the exam, there is what we call Jode-Basedow phenomenon. Jode-Basedow phenomenon. What is Jode-Basedow phenomenon? So you see, someone that is actually, you see, I love to use an analogy. In med school in Africa, so at least from where people, some of us actually finished from, so we didn't really have the opportunity of having most of these hands-on, visual and the likes. You can imagine the treatment, the teaching about the heart that they actually taught us. I'm very sure we imagine all the chambers throughout throughout our training. It's not that maybe they were showing us, you can see the heart, you can see this chamber. We kept on imagining from our secondary school. So our brain is now developed in such a way that our power of imagination is now very high. So when you find yourself in the United States, where you have a lot of resources, so the way you are going to be making things happen is going to be at another level. So that is the same thing that happens with respect to in Jode-Basedow phenomenon. The patient is actually has been iron depleted for a while. Can you get that? So the patient has been having, iodine depleted for a while, has been living in a place where the iodine deficiency is the order of the day. So by one reason or the other, you now give the patient something that contains iodine, the rate at which they are going to generate T3, T4 from it, you will be surprised. And that is Joad-Bezdo phenomenon. It's opposite of Wolf-Chaikoff. Wolf-Chaikoff will halve it. Joad-Bezdo will horn it. All right. So we can look at it like that. So you see, you'll be making reference to this, that then this patient had maybe a procedure. So then they gave the patient iron containing contrast or amiodarone. You now start seeing hyperthyroidism picture in the patient. You are now like, what is going on? So most likely the patient has been depleted of iodine. Most likely the patient has been depleted of iodine for a while. So when the patient is now exposed, the thyroid is now exposed to iodine containing solution, you see it start overproducing thyroid hormone. You call that Joad-Bezdo phenomenon. All right, you can see this thyroid adenoma. So this is it. So you just expect it to just be one single, mass that you can see there. Anyways, all right, but when you see it, you need to be very sure. I'm sure I'm not dealing with a tumor or a cancer or a mass, or I'm just dealing with something related to hypothyroidism. So this is thyroid cancer for you. So what do you want to take into the exam with respect to thyroid cancer? First of all, when you look at the TSH in the patient, it's basically going to be normal. So the TSH is going to be, you expect it to actually be normal. All right, so that's one thing, the first point you want to remember with respect to this. So how do you want to make the diagnosis? You make the diagnosis. Sorry, 1 minute. So how do you want to make the diagnosis? You make the diagnosis with fine needle aspiration. But before you are going to pick fine needle aspiration as your answer in the exam, you want to be sure that the ultrasound is done. And most of the time, you do the ultrasound guided fine needle aspiration. You do the ultrasound, you see, you take a biopsy. So this is what they are going to really be paying attention. Pay attention to this in the exam, so you can see the arrangement. So please note the arrangement so that you won't be seeing similar answer. I'll be saying that okay, I saw this, I saw that. What is the treatment? Treatment basically is thyroidectomy, which can be partial, it can be total. So thyroidectomy, just remember thyroidectomy. So in step 1, no one really bothers about is it partial or total. In step 2, we are going to break it down. Under which condition will you pick total? Under which condition will you pick partial? So that's what I want you to actually note in the exam. Help us to mute your mic, please. So that's actually what you want to note with respect to that. All right. So the next important point here is just for you to note the possible complications that the patient with thyroidectomy can have. The most tested in the exam is the hypocalcemia. Can you see all these points? So you just say all these things to yourself as you are going into the exam. So basically, then the next important point is you can damage the right laryngeal nerve. The external branch of superior laryngeal nerve can also be damaged. So sometimes they've tested this external branch of superior laryngeal nerve in a way, because you need to be very careful the way the patient, most especially in those that are singers, professional singers. So if this is, you do the surgery and this is damaged, they may actually lose their profession. So that's why I think they take it very seriously there. So you want to pay attention to that. So watch out for this being tested in the exam. Then these are the tumors. So papillary carcinoma, follicular carcinoma, medullary carcinoma. With respect to the papillary, this is the most common. Sometimes when you look at the question and you don't even know which tumor does this thing belong to, you just want to pick papillary because it is the most common. All right, so it's the most common, and we have this. You see, there is increased risk for this papillary carcinoma when you see this rearrangement or mutation in the exam. Red PTC, so then BRAF mutation. So BRAF is sound like a brother, BRAF. Maybe you can look at it like that. Then red, then PTC. You can look at this PTC like papillary thyroid cancer. So if I thought that makes sense, at least red PTC rearrangement will help you. Then there is one condition they love to test very well in the exam, the risk factor, and that is childhood irradiation, neck irradiation. So you want to watch out for this in the exam in case it's tested. That's why it's harrowed. All right, another important point for you to note is more or less about the histologic finding that you may actually see in them. All right, you can put it together like this. You call this the upper hernia. Upper hernia. It's just more or less like the nuclear groove that is in a way more or less empty. You can look at it like that. So empty appearing nuclei with central clearing. So that is upper hernia. So if you look at the name Papi, like Papa, then they also have another one, Mama, Samoma body, Papa, Mama. Then they have an orphan. So that is upper hernia, high, empty appearing nuclei. Can you see the way all of them rhyme? So you can get into the exam and just be bringing them out. Papi, papillary, Mama, Samoma body. So you see Samoma body in the question. Them testing it in a way. Then you see upper hernia high. Then childhood irradiation is a risk factor. They will mention it. And that's all. How does it spread? Lymphatic spread. Then you come down to the follicular. You see, follicular. When you hear the word follicular, I have a way of putting it. I just say that the rascal invaded my flat. The rascal invaded my flat. The rascal invaded my flat. The F in the flat is actually for the follicular. The rascal is telling you about the mutation you have here, which is RAS mutation. Invaded here is telling you about the attribute that we give it out, and that is invasion. So when you read it and you are seeing that it's actually there is a tumor or that has invaded the capsule vasculature, just know you are dealing with the follicular. The rascal invaded my flat. You can give it anyhow. Just give it something that in the exam at least you can remember, basically. So you need to be very careful. So fine needle aspiration cytology may not be able to distinguish between the two in a way. So that's just by the way. What of medullary? Medullary carcinoma. This is actually from parafollicular cyst cell. So you know this is definitely going to be related to calcitonin production. So another thing again you see is that you have this sheet of polygonal cell in an amyloid stroma. So what do you normally use to know that what I'm dealing with here is actually an amyloid? This is this staining. You call it Congo red staining, which means when you get into the exam, they tell you this patient has this also tumor of the thyroid, blah, blah, blah. They now mention something about the Congo red. You just know that it can only be related to medullary. It's just as easy as that. You just have that clincher and you just stay with it. It's just most likely good. And you believe that in the exam, that is how it's going to come. All right. So it's associated with what? MEN2. So MEN2A, MEN2B. All right. We put something here called mentullary. So mentullary carcinoma. So once you mention, you just say most likely this is going to be related to MEN2, MEN2A, MEN2B. And you know you are going to be dealing with Congo red staining of the stroma there. All right. What about the undifferentiated or anaplastic carcinoma? So you usually see this rapidly enlarging neck mass. This is the word that is going to give it out for you in the exam. This is the word you need that they were going to put. You just say that when I get into the exam and the question mention rapidly enlarging, we'll just go for anaplastic or undifferentiated. So can you see? You can see it's also having compressive symptoms like dyspnea, dysphagia, hoarseness, and the likes, and it's associated with TP53 mutation. This rapidly enlarging is the word you need that is actually, or the statement or phrase that is actually going to give it out in the exam. So when you are reading the question, you are looking at all these things, you just be like, this patient has anaplastic, this patient has medullary, this patient have this patient have that. So that is actually what you need. All right. For now, I'm going to actually stop here to allow you to rest. So that is the Concept Academy for you, for those that are listening to us. I can see Dr. Theophilus in Sofo. So nice seeing you. All right, so that's actually the concept. If you look at it, the what do we call it? USMLE just look like it's difficult. You are the one actually trying to put a lot. You are the one looking for too much detail. So